Okay, so ultrasound. Luckily for those of you from yesterday, this is a much easier topic. If your brain feels a little bit, I don't think I'm ready for more, this is going to be easier, so that's good. That will work. So this is my personal email address, jmvd1@aol.com. So with clinical questions, email me directly, that'd be great. If you need a new certificate or something, the front of the book is where to email. And those of you online, if you have questions, live chat. If you're not on a YouTube account, you can email info@jvbenterprises.com. And okay, so by lunchtime today, we're going to have gone over a little bit on history, so how ultrasound came to be, the physical principles of how it works, how the energy works, the equipment, how it works, physiological effects. That's the really important part, is what can you physiologically do with the ultrasound. You're welcome to stay back there and be hooked up as long as you want, as long as your skin can take it. So the physiological effects, you're welcome. You can have them if you need them.
I have mine.
Okay. Yeah. And then how to turn that into a good clinical application, and then designing a treatment program, how to come up with an effective treatment program. So that's our day this morning. I think this is working. History of ultrasound. According to a couple of textbooks I've read, ultrasound was accidentally discovered. There were some workers, I believe some sort of construction project underwater, and the workers were getting injured. So they were getting damage to their tissue. And when they tried to figure out what was happening, some of the equipment they were using had high frequency vibrations, and it was creating these vibrations which passed readily through the water. So water is actually a really good coupling medium for ultrasound. It travels relatively unimpeded if it's clean, fresh water with not a lot of air in it. And you don't feel ultrasound. When a certain amount of ultrasound is entering your body, there's no sensation, there's no visible response until it begins to be harmful levels and it becomes to be painful, noxious levels. So that's what was happening here, is they weren't aware that this was happening until it became potentially dangerous and noxious. So as it turns out, one of the methods of using ultrasound is for the purpose of tissue destruction and for doing damage. It's actually used for that purpose, especially with cancer treatment, to cause tissue to be vulnerable, combined with other methods. We're not using it for that reason, but the potential is there. With enough ultrasound energy, you can harm tissue. So that's the reason it's a skilled intervention, and used at certain intensities and frequencies, you have to be cautious because you could cause harm. There's also diagnostic imaging, which is the other extreme. It's a level of ultrasound that is low level. It's not enough to necessarily change physiology, but it's just going to bounce off its target to give you a picture or a diagnostic tool of some kind. I use it for assessing blood flow in the lower extremity by doing an ankle brachial index. I'm sure any patient has their suspicion of a DVT, and they do an ultrasound to diagnose blood flow. Those are all considered diagnostic ultrasound levels. Everybody's pretty familiar with somebody who's pregnant and gets a diagnostic ultrasound. It's used for many, many purposes to diagnose things. So that is also ultrasound, but it's a different frequency, different intensity. And then there's therapeutic. That's what we're going to be doing today. That's what we'll be talking about, is therapeutic levels. That's in the medium range. It's in the range of intensity that can create some sort of a physiological response. So the depth is variable. We have a certain range that we're allowed to use as clinicians, as PTs, OTs in this type of discipline, and our machines are pretty specific to that. So the alterable parameters, the things that you're going to be able to choose from. One may or may not be sound head size. A lot of machines, the standard size is approximately 5 square centimeters. This is pretty typical of what most devices will come with, unless you special request a different size. But they come much smaller. They come down to I think I have one back there that's 0.9 centimeters. So it's just under a centimeter, and it might be appropriate for you if you treat hands, if you need to treat very specific small targets, because if your head is too big, it's going to be difficult to couple, or they come bigger. I have a 10 centimeter head back there if anybody wanted to try it for a larger target. But even with the biggest head, you're still not going to cover a really large area. It's still going to be a relatively small area, because your sound head that you're using, with typical therapy treatments that we do, you're going to be able to treat approximately 2 to 3 times the size of that sound head in a reasonable amount of time, in less than 15 minutes. So typically, if you're going to be treating a very large area, for example, someone's low back, you really can't treat ultrasound effectively in someone's low back and that whole area. What you could do is palpate, identify trigger points, and treat an area about 2 to 3 times the size of your sound head, and that would be a more realistic expectation. So sound head size is something you may or may not choose. You may go back to work and have one head, it's permanently attached to your machine, and you can't make any choices there. Or you could go back and find that you have typically 2 or 3 heads is a reasonable expectation on your machine. And like this one, it would unscrew, and then the other one would screw back in. You can't just put a different head on. The machine itself has to be calibrated with the head itself. So getting a new head is a process that would involve a company making sure they calibrate properly. Frequency. I'm pretty sure when I graduated college, the machines that I typically was using only had 1 megahertz, and which is 1,000,000 cycles per second. Nowadays, the majority of machines have 1 and 3. So most of them have 2 frequencies, with 3 megahertz being more superficial, 1 megahertz being a little deeper, up to 5 centimeters. We'll go into the frequency and the significance of that here shortly. Intensity. You should have control over the intensity. How high you turn it up is basically going to alter the wave. So basically the magnitude of the wave, which has the potential to transmit more energy to the cells. And then duration. How long do you treat? So these treatments are typically in the range of 2 to 15 minutes. Beyond that is probably unreasonable. Your arm is going to get tired. They're going to get bored. Ultrasound is a boring treatment to deliver. It may be fun to receive it, can be very soothing, but it requires you to do repetitive overlapping movements over the area. From an outside perspective looking in, a lot of people look at the delivery of ultrasound and it appears to be non-skilled. It doesn't look like it requires a lot of skill, because you don't know what, if somebody outside looking, they're like, I could do that. I could push that button and move it around. But the skill is involved in you knowing what's under the surface, you knowing what you're treating, knowing how to assess and set the machine up. So there is skill involved. I think it's often misunderstood and maybe used in a way that people don't put the thought into what they're going to do, and therefore it does become a less skilled intervention. But done properly, ultrasound really is a skilled intervention which requires your thinking. Okay. How is ultrasound produced? So I'm going to use this thing again. Basically, your sound head has a crystal in it, and this crystal has what's called the piezoelectric effect. And the piezoelectric effect, early on it was discovered that certain crystals naturally occurring in the environment had this phenomenon. It had the piezoelectric effect, which was if you hit it. A lot of times if you look at a textbook, it'll show a little crystal and it'll show a hammer hitting. So basically, if it physically was hit, you would get a little electric charge out of it. So these are products where physical pressure on it will cause it to release a little bit of an electric charge. And what they discovered is you could use the reverse of this. So what your machines are doing, what your sound head is doing, is called the reverse piezoelectric effect. So this blue that you see here is actually a crystal. It's not quartz like the early ones. It's a man-made crystal that imitates the piezoelectric effect. And what's happening is the electrical current passes across it. When the electric current passes across it, it vibrates. So you reverse it, it now vibrates at the rate that the current changes polarity. So that's what's happening with your ultrasound head. Now, those are mounted in here. You know, let me go back just for a second. This particular manufacturer, this is a Mettler head. They have their crystal exposed. It has a protective coating on it that's blue. The majority of machines, and I'll hold this here for a second, the majority of machines are metal. And so they would look more like this. And what you're looking at here is a metal housing. If you were to take it apart, I wouldn't advise that, but if you were to, the crystal would be on the other side of this metal. So it's mounted in here. And that's how it's vibrating and transmitting the energy out through the metal head. That's more typical of what you're going to see out there. The difference here is you can't see it. You don't necessarily know how big your crystal is. So you have to look at the device, and they have to be labeled. This is something that the FDA requires, is they require your devices to be labeled, and it'll tell you essentially how big your crystal is. Most machines, the crystal is pretty much as big, as close to it can be, as it can be to the head size. This one you can see is almost the entire head. There's a little bit of a mount around the edge, so it's not quite as big as the actual head. And that's the majority of machines that I have ever used, that's how it was. Now there was one particular manufacturer. I remember there was a head that kind of, you know the Starship Enterprise? It kind of looked like the end, it was like a pancake at the end of it. So the handle came out, and then it was an enlarged head. And if you looked at the handle, even though the size of the head was probably in the range of 10 to 15 centimeters, square centimeters, it actually had 3 square centimeter crystal. So if you looked at it, for example, if I look at this head, it says 5 square centimeters. And if you were to measure, that's approximately how big this is. So if you have a metal housing, you really do need to look and make sure that you know how big your area of treatment is so that you don't treat an area that you're not effective on. So we'll talk about that more in a minute. Okay, so that's the idea of the crystal and how it works. Terminology. We talked about frequency yesterday with E-stim. Frequency, you use that term, it's just how many. It's just how many there are, how many waves or beats or something like that. So 1 hertz is 1 cycle per second. And if you think of it as 1 wave on the ocean, if you think of it just as 1 wave, it's 1 complete peak and trough. A kilohertz is 1,000 cycles per second. And then a megahertz is 1,000,000 cycles per second. So what we're dealing with here with ultrasound is megahertz. It's in the millions of cycles per second. Anything over 20,000 hertz is considered ultrasound. So there's a long range. So from 20,000 on up is classified as ultrasound. And there's a lot of different things that are done with it. We already talked about therapeutic versus diagnostic versus damaging type energy. So basically anything over 20,000 would be considered ultrasound. So there are devices that are often called low frequency ultrasound. They're in the thousands. So they're from 20,000 up to just below 1,000,000. If you do wound care, we talked about wound care a little bit this morning, there are devices such as the MIST, Sonica, I don't know if you've ever used any of those. They're used for wound bed, debridement, and stimulation. Those are in the low frequency range. So those are usually in the 20 to 25,000 frequency range, and they are therapeutic and they are useful. More typically though, what we're going to be talking about today is millions of cycles per second. So from 1 to 3 million cycles per second, 1 megahertz and 3 megahertz are the most common, but you may see a slight variation when you look at different manufacturers. They may be right around that range, but just slightly different. Simply, probably just to make themselves unique, but there may be some reason that they give why they go slightly above or slightly below what other people are typically selling. What you can hear, the audible sound that we're capable of hearing is between 16 and 20,000 hertz. If you think about tone, think about what your voice sounds like, that's the frequency is what changes it. Low frequencies are deeper, higher frequencies become more high-pitched, and then beyond, you can't hear it because the vibration level doesn't travel well through air, and it's not capable of being perceived when your ear vibrates. In your capacity to hear it you can't. Okay, so that's the idea of ultrasound and where the frequency is. So think about how it's transmitted. One of the ways to really, that I think of using an analogy is similar to the sound that you're hearing anyway. It's basically the same energy. It's just simply a vibration. I definitely, at a college level, when I was taught ultrasound, it didn't really make sense to me. I do remember thinking more along the lines of ray beams or laser type of things. What I didn't fully understand is that ultrasound is just a vibration. That's all it is. It causes molecules to vibrate. So what's happening is, as in this picture, you have an alternating current. Your machine is creating it. There is the machine is calibrated in a way that it will cause an alternating current to vibrate at the rate you're looking for. So your crystal is going to expand and contract in relation to the vibration that it's receiving, the frequency that it's receiving. And what's going to happen is it's going to create a pushing and pulling force. Have you ever been next to a car on the street and they've got their bass, the music is really loud and their bass is going and your car's vibrating, or if you go to a concert? I know I've been to a few concerts where we were probably too close and it was very loud, and if you close your eyes you can actually feel my hair moving. You can feel it, on your body. So sound is physical. It is a physical vibration. You could be completely deaf, have no ability to hear whatsoever, and you would know whether there was noise in the room or not. You could feel it. If you were in a silent room and somebody walked in and made noise, you'd feel it. So a loud room would feel very different. It kind of follows the lines of what we were talking about earlier with frequencies and so forth. It can have an effect on you, can absolutely feel the level of sound and energy around you. So if you just think about that, the wave that's created with ultrasound is the same type of wave, it's just a different frequency. So it's pushing and pulling, and it's causing the molecules in your tissue to vibrate. And one molecule vibrates, and then the next one does, and then the next one, and it passes on and on. If you think about at an arena, when they do the wave, how the wave goes around, think of the people in the arena as the cells of your tissue. So basically you've got the cells in your tissue, the molecules of your tissue that vibrate. And then when they vibrate, and then it moves on to the next one, and then the next one. It's the same idea. The intensity is kind of the height of the people in the arena. It's how hard you push. So if you're pushing harder, it's more of a mosh pit than the wave going around an arena. So the intensity of that pushing and pulling. And then the frequency is how fast it goes and how fast that vibration occurs. So that's the basic premise of ultrasound and how the energy is passed on. And when we start talking along the lines of the density of your tissue, the frequency, the intensity, all that stuff kind of makes sense when you think about that same premise, that same analogy of people vibrating. The higher the frequency, the shorter the wavelength. Does that make sense? If it's a higher frequency, it's going to go smaller. To be that fast, the length of the wave goes smaller. In the range that we're talking about, 20,000 hertz and above, you need a dense medium. The higher the frequency, the less the excursion of movement is going to be, and the more dense the medium needs to be. So I could turn on my ultrasound, and I could get right close to you, right close to the body, and I could turn it as high as it'll go, and that energy cannot get to you. Any air in any gas in between, the molecules of a gas are so far apart that that vibration can't affect the next molecule. They're too far apart. So anytime there's something in the pathway of the ultrasound that can't vibrate at the frequency and it doesn't have the capacity to pass that energy on, it's not going to transmit. It's going to act as a barrier. So air, gas is a big one. This is why when you couple, you can't be going off the edge. If you get air in the path, ultrasound can't pass. It's got nowhere to go. So it's going to cause the ultrasound head to get hot. And so if the energy can't leave the ultrasound head, if those vibrations are building up in there, then you're going to get hot. The head's going to get hot. Now, how it goes through the tissue. Okay. The way it passes through the tissue is primarily longitudinally. So when you look at waves, ultrasound goes pretty much where you aim it, and it's going to go in that direction. Now, if it hits something that's a significant change in density, it can scatter. So think of it as your voice, you know? These rooms like this are designed for absorbing sound. You've got sound absorbing ceiling tiles, you've got carpet, you've got textured walls. So rooms that are intended to have sound be delivered and not reflective are going to have nice absorbent type of surfaces. Versus if you've ever been in a room, I can remember a whirlpool room where the walls were marble tile, very flat, and the sound bounces off the walls, and it's very, you can't hear anything because the reflected vibrations interfere with the original vibrations, and it disturbs all the sound. So reflected energy can combine with the incoming energy, and it causes the wave to be disrupted. Okay, so what can happen is these waves are coming in, it encounters a significant change in density, and it can cause them to kind of scatter and go different directions. So when we talk about ultrasound, we want to talk about attenuation. Attenuation is basically when you go from one place to another, you lose energy. And how do you lose it? So how does that energy get decreased? One is reflection. So reflection is going to happen when there's a significant change in density. And think of it again as any reflective surface that would, if your voice would reflect off of it, same idea, it's going to reflect. The most common place this happens is scarred, thick, calloused, dry skin. So the level of the skin, if your coupling medium doesn't help transmit it, or if the tissue is just too thick, acts more like a solid, the energy is going to bounce right off and it will not enter. So sometimes you have a site that you would like to ultrasound, but it's not a realistic target because you really can't penetrate. The second most common place is at the level of the soft tissue bony interface. So when your soft tissue meets the bone, you go from your soft tissue, which is a little bit more like a liquid. It has that density more like a liquid, and then you get to a bone, which is a solid. Whatever energy's left, a lot of it will reflect back off in the other direction. So this can actually make just above the bone a really good target, because what can happen is your energy's coming in, it reflects off and meets incoming. So what happens is that the new incoming waves meet the reflected waves, they combine right there, and right at that periosteal and just superficial to the bone, that area is going to get more energy accumulating. So this is why with ultrasound, you can heat and deliver more energy to deeper structures than superficial structures. So you can be getting hotter and more physiologically affected at the deeper level than up here because of the nature of how it reflects off. So that's very unique, and it's very helpful to know that information, because sometimes you don't want that to happen. The challenge is if you're treating something in the area superficial to it, but it gets hot down here. That can be a challenge to try and target something midway between the surface and the bone. It's hard because those tissues are just simply hard to isolate. Okay, so that's reflection. Refraction is not something we really utilize. It's an unfortunate thing that happens. And what happens is as the ultrasound energy is passing through the tissue and it encounters a change in density, but it's not significant enough to go back the direction it came, it causes it to just bend and go off the straight path. And this causes it to scatter. And so anytime you're doing ultrasound, as soon as it enters the body, even in your coupling medium, it's possible that if your coupling medium isn't ideal, it may already have started scattering a bit. So what will happen is it takes your uniform energy that's coming out of your sound head, and it's making it non-uniform, because this happens non-uniformly. So it's causing it to spread and become less dense and less uniform. I like to describe it as like a flashlight. So if you've got your ultrasound and, if you think of it as a flashlight, as it comes out, if you're shining that light directly on a surface, it's going to be pretty bright, and the area is going to be pretty synonymous with this, what's coming out. But if you start to pull it back and it goes further and further, this cone of light gets less dense, less sharp, and it becomes wider and wider, kind of like a projector, which is getting significantly bigger. So the idea with the ultrasound energy is the further it goes through your body, the more it becomes like a cone and it spreads a bit, and the less dense it becomes. So clearly, if you're treating a superficial target, the amount of energy that's capable of getting there is going to be more dense, it's a little bit less scattered. The deeper you go, the higher you're going to have to go on your intensity, because by the time you get there, it's going to have decreased by these different attenuation ideas. Okay, so that's the idea of refraction, and it spreads a bit. That also helps if you're thinking about contraindications, precautions. If there's some target that you want to avoid, you know, let's say they have a problem with their shoulder and they have a pacemaker. You know, a pacemaker, unlike E-stim, which is a pretty much don't put it on them at all, anywhere on their body. With ultrasound, as long as the energy itself is not going to encounter that pacemaker, you're fine. So, you know, if somebody has a pacemaker, I could ultrasound their lower body, absolutely no problem. I could be on their back, I could be on the opposite shoulder. There's no way that energy is going to travel across their body and get to the pacemaker. But if I'm in the same vicinity, maybe it's, you know, if their pacemaker is in their chest here, and I want to treat this shoulder, then I really have to make sure that my target would allow me to aim the ultrasound in a way that it's not going to possibly encounter the pacemaker. So it's more a matter of knowing how the ultrasound travels, and the fact that it goes where you aim it. And if you aim it this way, it's not going to go this way. It's not going to take a 90-degree curve. However, if it's in the path, but a little over the side, depending on how deep you're going, it could possibly spread and get into that pathway. So that's another way of thinking of it. And then there's absorption. So the third thing I want to talk about is attenuating through absorption. And the idea that every cell that gets vibrated keeps some of the energy with it. So it took energy to vibrate it. And sometimes that's all you're doing. That's the physiological effect we're looking for, is just to take that cell and shake it up a little bit. So to some extent, that is our physiological effect. Now, if that happens enough, the kinetic energy is absorbed, and if it happens enough repetitively, then the tissue becomes heated. So if that vibration occurs enough, that tissue starts to get heated up. So it's either just the act of shaking it, or the act of doing it enough. But the absorption occurs, the more it penetrates, and the type of tissue and the bond it has with the tissue around it. So you know how all tissue is not created equal. The bond between two cells is different in your ligament and tendon versus your muscle versus your skin, and that's also going to affect how it penetrates and what it does to those cells, how much energy is absorbed. There was a study, this is actually an old study, I haven't seen a newer one done, so take it with a grain of salt in the fact that it was one particular study where they looked at skin versus fat versus muscle versus bone. And they looked at, when you pass through a layer, an equal layer of each, how much energy came out the other side. They looked at how much was lost within that layer of tissue, and they found that 39% was attenuated in the skin, so that's either absorbed, reflected, refracted. 13% was lost in the fat, 24 in the muscle, and 96 in the bone. So to me, that tells me that, you know, when you think about what's harder to penetrate, if I have a target that lies under a thicker layer of fat or a thicker layer of muscle, which would you be more likely to be able to get through? The fat. I mean, it would be easier to penetrate, meaning it would be easier to get to the target because less is attenuated in the fat, which is the opposite of E-stim. That's much more difficult to penetrate. So if I'm looking at someone and I'm thinking about doing ultrasound, but the target is, let's say, the joint capsule or the tendon underneath close to, say, 4 centimeters of tissue, my question would be, could I get there? If it was thick skin and 3 centimeters of muscle, my chances of getting there are lower than if it's thin skin, mostly some adipose tissue, and not a lot of muscle. So thinking about could I get to a target isn't just the centimeters of depth, it's how many centimeters of what, and is it acting more like a solid, is it more of a muscle? That's gonna really help dictate whether you think you can achieve it or not. Okay, so that's the idea of how it goes through the tissue and how the energy gets distributed. Now, when we look at depth of penetration, 1 megahertz is 1 million cycles per second. 3 megahertz is 3 million cycles per second. The 3 megahertz, I mean, when you think about it, a good example as to why this happens is friction. If you rub your hands together 1 time per second or 3 times per second, the friction that's created is a lot more with 3. The energy it takes to vibrate that fast is going to cause you to absorb more energy, takes more energy. So the 3 megahertz, it doesn't go as deep. It gets absorbed at a superficial level. The ability to vibrate at such a fast rate causes it to be reflected, refracted, and absorbed at a more superficial level. It also is a higher intensity. So the ability of it to cause kinetic energy absorption and potentially heating up a tissue is greater as well. So there's 3 times more energy, more vibrations being delivered, but it can't go very deep. So if you have a target that lies more than, even close to 2 centimeters, you're going to have to go with 1 megahertz. So 1 megahertz has been found to go up to 5 centimeters deep. If you have a target that's deeper than 5 centimeters, it's unlikely ultrasound is going to be a modality that you can even use. It's just not likely to reach your target. If you have a target that is less than 2 centimeters, 3 megahertz is likely going to be the frequency you're going to choose. For me, if it's close to 2 or deeper, theoretically, if I'm looking at the target, and I don't know exactly how deep it is, but I'm assessing and I'm thinking it's in the range of 2 centimeters, I'm more likely going to go with the 1 megahertz. Because even though it's capable of going to 2 centimeters deep, that's scientific studies. And in an actual patient care environment, the possibility that it won't achieve my target, I want to make sure it at least gets there. So I would go with 1 megahertz if you're close to that cutoff point. And then it's been found to go 2 to 5 centimeters deep. Okay, any questions on that? Now, when you look at your equipment, there are certain things that the FDA requires it to be labeled for. And when we talked about the size of the crystal, it's directly related to your ERA. It's called your effective radiating area. And that basically is how big is your crystal and how good quality is it? Is the whole thing vibrating? Is it creating a good full field? So this is just a picture of one ERA that's almost the entire sound head is creating an energy field versus one where just a portion of it is. If you were to cover a treatment area with the same exact method, you wouldn't get as much energy with a smaller ERA as you would with the larger one. So it doesn't mean you can't use the device. It just means you have to treat the area, a smaller area, if you want to get good outcomes. The reality is you're not always going to know this. When you have your equipment inspected, they should be checking this, and they'll be saying it's still within acceptable limits of what the label says, or they have to let you know that it has some discrepancy in the frequency, the intensity, and the ERA. You're required to have a label. It will be on your device. So if you look at this sound head, it has your ERA 5 centimeters square. That means the field that's created is 5 centimeters square. So I could theoretically treat an area and heat up an area about 15 square centimeters in size. Beyond that, based on current evidence, it's probably not likely within a reasonable period of time that I could heat up an area more than about 3 times the size of my sound head. So that would be my expectation. Does that make sense on an ERA perspective? A lot of times I'll say it's like ironing. I like to use an analogy, is if you were ironing and your iron only heated up in the middle, you're not going to be able to iron this way you would if the whole head of iron heated up. It's a similar idea in the fact that you could treat a larger area with a larger field, a larger head, a larger crystal, and a larger ERA. Okay. Intensity. So this is a picture of intensity at the side. So if I was to hold my head up and that ultrasound energy was coming out of it. The near field, those first centimeter or 2 centimeters, is going to be relatively collimated. Now this isn't going through water. Now if you add a medium that is not as uniform, you're going to become non-uniform very quickly. So what happens is that energy is, as it's penetrating, as it reflects, refracts, and absorbs, that's going to happen non-uniformly. And what's going to happen is the field of energy is going to become quickly non-uniform. So if I was to take a cross section and I look at the energy that's being distributed in your tissue, for example, it's going to be non-uniform. You're going to have developed uneven amounts of kinetic energy being delivered. So we can think of that in the form of heat, in the form of treatment outcomes being non-uniform. So if I was to hold the head still, which I never would, you always move your sound head. It should always be moved so that what happens is you're taking this non-uniform pattern of energy and you're moving it around to try to make it as uniform as possible. So that's the reason you always move your sound head, is to try to make this non-uniform energy into a uniform as possible, because if you don't, these hotspots are going to build up and you're going to end up with small pockets of too much energy, too much heat, and they're going to get potentially harmed. They could get potential small burns in their tissue. Okay, so that non-uniformity can create hotspots. The abbreviations here, the SAI, is the spatial average intensity. Your spatial average intensity is, if you were to take a cross-section and say the average amount over the whole field is going to be this many watts per centimeter squared. And so it's the power divided by the ERA, the total power coming out, divided by the square centimeters of your sound head. And a typical spatial average intensity is, say, 1 watt per centimeter squared. And what that means is per every centimeter of area you're treating, it's getting approximately 1 watt. To make sure that you're getting that even amount, you want to move as uniformly as possible. Move your sound head. Now the BNR, the beam non-uniformity ratio, is the ratio from the peak, so the hottest spot in the beam related to the average, and that cannot be more than 6 to 1. If it's more than 6 to 1, in the United States, that machine is not allowed to be used because it's considered unsafe. So we are required to get our equipment tested, calibrated, and it has to meet those requirements in order to be sold in the United States. Actually, a good question about portable ones is, do they follow those same standards? I'm not sure, actually. But basically, when you get your equipment inspected at a minimum of once a year, most of us follow the once a year because that's a Medicare requirement. It's a licensing requirement for most licensed facilities at a minimum once a year. Now, if your equipment gets used a lot and you ever suspect something's wrong, get it inspected, get it checked, because you can't tell by looking at your machine if it's working properly. I'm going to show you a little method where you could put a piece of packing tape around your head, put some water on there, and you can turn it on, and you can get a visual look at the field, but it still is not going to tell you if something's wrong. You're not going to be able to tell. You would have to get it inspected by someone who has the right equipment to tell what is happening, to make sure it's within safe ranges. Okay, so your beam non-uniformity ratio must be 6 to 1 or less. Let's say your BNR is 5 to 1. Let's say you're within the range, which is very typical. Most machines are in that range, right at that range of, where they'll tell you, this one says 6 to 1 or less. What that means is we're within regulations. We've met the regulations. I don't know exactly what this head is at any given time, but I know it's at least 6 to 1 or less. So let's say that it was 5 to 1. That means if I'm delivering 1 watt per centimeter squared, somewhere in the beam it's 5 times hotter. I'm delivering 5 watts per centimeter squared. So the peak is going to be significantly hotter. Again, when you think about how the energy is distributed and you understand that it's non-uniform and towards the center of the field is going to get hotter, it's going to help you do safer treatments, especially if you're being on the aggressive side and you're using thermal levels, knowing that certain places have the potential to get more heated. So you definitely want to center your head over the site that you're really trying to focus the energy on. Okay, so pulsed ultrasound, or duty cycle. When it's pulsed, that means it's on at the rate you chose, and periodically it's just off. So if I chose 1 or 3 megahertz, it's going to be on at 1 or 3 megahertz while it's on, and then it's going to be off completely. So a very typical, most common duty cycle is 20%. It's the most commonly studied. It's what our research is most provided. That's why chicken or the egg. Did our manufacturers put 20% available to us because of the research? Or was the research done at 20% because that's what's available? I'm not really sure, but regardless, on machines that offer these set frequencies, set duty cycles, 20% is the most common one that's offered. So at a 20% duty cycle, it's only on 20% of the time, it's off 80% of the time. So an example would be 2 milliseconds on, 8 milliseconds off is a very typical example of what it would be. So what happens during 2 milliseconds is the physical vibration, the energy is delivered. And then during the 8 milliseconds, assuming you have blood flowing through that tissue, the blood flow is going to negate any temperature rise that there was. So in the 20% on, slight, energy deposition, slight rise in temperature, 8 milliseconds off, blood flowing through, brings it back down again. So the difference between just doing a low intensity is that you can have a higher intensity when you think about it as sort of shaking the cells up, but you can still not have a heat rise. So this would be when you want to get a kinetic energy without the temperature rise. Okay, a 50% duty cycle, just another example, would be off the same amount as it's on. So if it's on 2 milliseconds, it'll be off 2 milliseconds. On, off. Same idea. Your chances of having a buildup of heat is better with 50%, but still not likely if you have good vascular tissue. 100%, which is on continuous, is what you want to use if your goal and your intention is to heat up the tissue. Go with continuous, 100%. It's on all the time. If you don't want heat, most typically we're going to use 20%. I haven't seen a lot of research studies using 50%. Certainly you could use 50%, and it just wouldn't necessarily reflect a lot of research studies that I've read. So I'm not sure what you would be using it for. So when we think about what ultrasound does, I want to talk about the thermal effects. When I first started learning about ultrasound, the most common thing we used it for was heat. And if any benefit that we got from the ultrasound, we credited the heat as being the reason. If you want to heat up tissue, as we just said, you want to use continuous mode, 100%. The way you're heating the tissue is absorbing the kinetic energy. So cells are vibrating, they start to heat up. If enough of this happens over a period of time, the tissue gets warm, it gets hot. The therapeutic ranges, if you look at the benefit of heating tissue, our tissue can be between 98.6 and 104 degrees, and I use Fahrenheit, it's just because that's the most common thing we use in the US, but when you get beyond 104, there's a range that's considered therapeutic. So the lower therapeutic range feels good, increases blood flow, and then as the temperature goes up higher and higher, the potential for increasing the ability of stretching the tissue. So the tissue becomes more ability to, that's what I'm looking for. It has the ability to stretch and more flexible and more permanent stretches without soreness. So a lot of times if you want to heat and stretch a tissue, you're going to want to go into those upper ranges. And that's simply based off on research that shows lower therapeutic ranges are good for blood flow metabolism. The higher you go, the more potential for that tissue to be pliable and increase that plastic effect of stretching. Beyond 113 becomes dangerous. It's not an exact science. Some patients, all tissue is not created equal. The amount of blood flow, sensation, it's all variable. This is why it can be a potentially dangerous modality. We have to make sure we keep people safe because even small hot spots could potentially damage the area of tissue that you're focusing on. So patient selection is going to be important, target tissue is going to be important, making sure you pick the right modality for the right location in order to get good effects and make sure the patient's safe. Now when you think about frequency and the idea of, so far we presented it more as depth, you know, it's the driving factor. If you have a target tissue that's deep, 2 centimeters or more, you've got to use the 1 megahertz. It's not gonna, you're not gonna achieve that target if you use 3. Beyond that, if it's very superficial and you use 1 megahertz, your potential for discomfort is great. So you're gonna pick primarily based on the depth of the tissue is gonna help dictate your frequency. However, it's also gonna affect your intensity. I mean, when you think about it, when you pick 3 megahertz, it's more superficial, so already you know you're not going to lose as much energy. And you also, because simply the attenuation, you're not going to be going as far, but also it's 3 times faster, so it's a higher frequency. So when you think about the potential ramifications of that, it is more kinetic energy, potentially more heating, and it's superficial. So that's going to come into play when we pick our intensity and our length of time of treatment and all that stuff. Unstable cavitation. So cavitation, the word cavitation means the creation of bubbles in a liquid environment. So basically, if you've ever been looking at the propeller of a boat as the boat's going and it creates all that air, or if you think about creating, you know, if you have a little amount of water, if you have a little bucket of water and you want to create air bubbles in it, you agitate it. You stick your hand in there and you agitate it. It's like making a bubble bath. The more agitation, the more bubbles you're going to get. So what happens is with ultrasound, when you pass ultrasound through water, you're agitating it. And you create little gas bubbles. The higher the frequency, the smaller the gas bubbles are going to be. So you're going to create these bubbles that are approximately that size related to the frequency that you're using. So because we know that ultrasound creates bubbles in a liquid environment, it's anticipated that because our bodies are mostly liquid, that it's creating cavitation in our soft tissues. So basically this cavitation is credited for some of the benefit. Now when I was first learning ultrasound, I remember as a student the word cavitation scared me because I thought, if I create a bubble in their blood vessel, could I not hurt them? Could that not injure them? The fear was there that I was going to cause some harm. That's not the case though. If you're ultrasounding, the cavitation that's created over the liquid environment is not a big enough bubble to cause any harm. So that fear that I had was unfounded. There was no reason for me to be afraid of it. And in fact, what I learned, and in my mind the word made me a little fearful, is now credited with some of the benefits. So this cavitation is actually credited with some of the benefits we get, which could be heat. The cavitation that's created in a continuous environment is credited with some of the heat buildup, and it's also credited with some of the energy that's related back to the non-thermal effects as well, which we'll talk about next. Let's talk about density of tissue, what type of tissue we're dealing with. The more dense the tissue, the more heat is absorbed. So when you think about that, some tissue is more absorbent than others. All tissue is not created equal. And also, the higher the vascular flow, the quicker that heat is going to be dissipated. So low vascular tissue will hold heat longer, and high density tissue will absorb heat faster. So all tissue is not going to heat up the same, and it's not going to be susceptible to the effects of ultrasound as much. So when you think about the types of tissue we might be treating, let's say the tendon versus the muscle. A tendon is more dense and lower vascular supply than the muscle tissue. So tendon is going to heat up faster. It's also just geographically located close to the bone, so it's going to be easier to target. Tendons are usually more superficial, and they're located where there's less soft tissue available. So a tendon is going to heat up much faster. It also has low blood flow, so it's going to retain the heat longer. Same with a joint capsule or a ligament. So those types of tissues. When you look at research studies as well, the nature of the collagen that's in those connective tissues make them more absorbent. So I like to think of it as sort of the rubber in the bottom of your shoe that is energy absorbing. The idea that the collagen, the type of collagen in those connective tissues, they're meant to absorb energy. That's what they're designed to do. That's what their job is. So when you think about it, they absorb more energy. So they can be, you can target them more easily, and they're going to absorb the heat more. Now when you think about muscle tissue, yes, it is dense, but it's very vascular. It's a different type of collagen. So when you heat a muscle, when you attempt to heat a muscle, it's going to be more difficult for it to retain the heat. And so when I do a treatment, let's say for a muscle spasm over an area of maybe a muscle trigger point, or an area where you feel an isolated area of denseness in that muscle, I'm going to do typically longer treatments than I would do on the tendon attached to that muscle, simply because it's harder to heat it up. The effects won't be as long lasting, but the effect would be more blood flow, and that could be of great benefit. Versus in the tendon, my goal might be different. My goal might be to heat it up, but more for a stretching purpose. So when you think about the type of tissue you're treating, your intention is likely going to be different. Your treatment may be delivered differently. The method in which you deliver the treatment and the position of the patient is likely also going to be different. So that's how you want to think about it. Yesterday I was talking about, I had gone to a course, David Draper. There was a study that we read in college, and it was called The Stretching Window Revealed. And the Stretching Window Revealed, this study looked at, it was this author, Draper, that wrote the study, and he heated up various tissues. And he looked at how long does this tissue retain the heat. And one of the things that was interesting was, various tissues obviously are going to cool out faster. But in my mind, what stood out to me was 4 minutes. That basically within 4 minutes, the tissue had, pretty much all the tissue, had gone out of the therapeutic window of stretch. And he's an athletic trainer and researcher, and in my mind, that the purpose of these studies was, and the purpose an athlete might be using these modalities would be to heat and stretch a tissue, make it longer, make your range of motion better. And so this study, the stretching window, was basically if I heat this tissue up, whichever modality you're going to use to heat it, but you heat it up nonetheless, and you get it into that window where your stretch is going to be more effective, that plasticity. You don't have a lot of time, because when you're done with your treatment, it's going to cool off quickly. So it was basically the 4 minutes stuck in my mind, and then 15 minutes was basically everything's back to normal. Everything had the capacity to be cooled off completely. So when I do a treatment, if my purpose is to increase range of motion and stretch something, I'm going to think about when is it going to be the hottest? When am I most likely going to be in that window, well, while I'm doing it, right? The most likely time, the warmest time, the hottest time that tissue is going to be at that peak is going to be while I'm doing the treatment. So when you tailor your treatment, if the purpose is heat and stretch, I always encourage people to put the person in a position of stretch, or do a dynamic stretch while you're doing the treatment, or have the patient self-stretch while you're doing the treatment. And certainly think about the post time, because I've seen a mistake made where, let's say somebody had a tight shoulder, and you're trying to increase external rotation. Well, some of the mistakes I'll see is maybe that person's in a nice, comfortable position. The therapist is doing the ultrasound, they're having a nice little conversation while they're doing it. And then when the ultrasound time goes off, they clean their head up and they wipe all the gel off the patient, and then they proceed to do a stretch. If that's the method and your goal was to use that heating period, you've lost your best possible window. If that first minute or so of time, you're already losing your heat. So what I would recommend is that same idea, either put the person in a position of stretch, have them in a way that you're stretching them. That would be ideal, that you could be providing a stretch that you can feel through your palpation skills, whether you're close to the end range, going into the end range, give it a break, go into the end range, utilize the modality while you do your stretch. And then certainly be prepared. As soon as you're done with your ultrasound, if you're going to do joint mobilization, which requires 2 hands or something, put your head down, clean up later, and go right into your joint mobilization technique and utilize the most optimal time to take advantage. That way you're using your modality to the best possible advantage. Okay, so that's the idea of different types of tissue, how it absorbs, how quickly the energy is dissipated, and what are you doing it for? And make sure whatever you're doing it for is the rest of your treatment helps optimize that and get the best results. Okay, so what can heat do to tissues? It can increase the pain threshold. It feels good. So it just makes you feel good, and that relates back to the gate theory. So in the E-stem portion yesterday, we talked about the gate theory, and you just close the gate. So basically, heat is a non-painful stimulus. It affects nerve conduction velocity, and it directly relates to that gate theory as well, and it relieves pain. So if you do ultrasound and you do it thermally, if they had pain to palpation before, the pain will be reduced afterwards. Whether that's a permanent and long-lasting is what our goal usually is, but regardless, just the heat itself will cause some pain relief. The increased nerve conduction velocity is related right back to that whole gate theory. You have increased blood flow. Your body doesn't like to be outside its normal temperature, so when it is, blood flow is increased. You have vasodilation, blood flow increases, trying to bring it back down to normal. That can be a good thing. That can help with muscle spasm and so forth. If there's an increased enzyme activity. So with an increased metabolic activity, increased blood flow, there is going to be an increased enzyme activity, and that's some of the healing effects that we'll talk about. There's an increased soft tissue extensibility. When you get into that slightly higher therapeutic range, the soft tissue extensibility the tissue becomes more pliable, you can stretch it with a more permanent lasting. I like to think of it sort of like a rubber band, or some sort of a plastic or rubber. When you heat it up, you can stretch it. If you keep it stretched while it cools off, it maintains that stretch. So that's another thing I think about, that same example of the person where you're doing the ultrasound, you're stretching them into some external rotation. Well, what you do then is, as soon as you're done with the treatment and you do your mobilization, you do any stretches you're going to do, have them use that range. Have them keep using that range. And I would say, theoretically, for the next 5 to 10 minutes, while the tissue goes back to its normal resting temperature, use the range, and then find something functionally they can do over the next 24 to 40 hours before you're going to see them again, to again make use of that range. Whether that be an exercise, pushing a wheelchair, transferring, propelling a wheelchair with their feet if it's that lower body that you're working on. So find some way to use that range in order to maintain what you just gained. Okay, muscle spasm. You can decrease a muscle spasm with ultrasound. Now, whether that is because you relieve their pain, the muscle spasm reduced because there's protective, whether you increase blood flow, and therefore what was causing the spasm was a balance of lactic acid or other metabolites, and then you correct that, or whether it was soft tissue extensibility and you stretch some of those structures. Either way, the higher levels of heat for longer periods of time has the potential to give you a good outcome. Okay, so that's heat. Now let's switch gears and talk about the non-thermal mechanical effects. So back early researchers, when early researchers were using ultrasound, it was most credited with its heat. And even myself, I graduated in '91, I remember in my mind thinking that the majority of treatments you do with ultrasound, any benefit you're going to get is due to heat. That was just the way our thought process was, and that's what most of the research studies credited. So what happened is, you can see I wrote in there, explanation of proven clinical benefits. There were some studies done, I believe David Draper was one of them, that did a study where they looked at tissue and they looked at common setup, common parameters, and they had the ability to measure the temperature rise. And what they found is there was a common setup that people used, which was a 20% duty cycle. So when they looked at ultrasound being delivered at a 20% duty cycle, there was no heat. There was such a negligible amount of heat that the finding of this study was, well, whatever benefit was gained in these clinical studies cannot be credited to heat. Something, there were some really good studies, good controlled studies that had been done, and they had done treatments at, say, 1 watt per centimeter squared or 0.5 watts per centimeter squared delivered at a 20% duty cycle. And in the findings, certainly the outcomes were improved. The control group did not improve as much as the treatment group, and it was mostly healing. Tissue had healed faster, it had healed better. The breaking strength of the tissue was stronger tissue. So there was benefit in the healing process. So you don't want to throw out, what is that saying, the baby with the bathwater? So you don't want to throw out the results of these studies that were actually well designed. What you want to do is provide a new explanation and discussion and say, well, if we go back and we look at these clinical benefits that were proven quite well, it wasn't heat. It couldn't have been heat, because if these machines work the way our machines are working, they found that at any intensity, at a 20% duty cycle, there just wasn't enough heat to possibly cause those benefits. So they went back and tried to explain the already proven clinical benefit. Why would tissue that's delivered at a non-thermal level have gotten better? Why would it have healed faster? Researchers are still trying to figure that out today. There's a lot of opinions and there's a lot of studies that have given us pretty good explanation. It's still a hot topic though. It's still something that they're trying to capitalize on and understand better. So when you do a non-thermal treatment, and actually a lot of books that I've read, or a book that I read, recommended not calling it a non-thermal treatment. The reason is, it makes you assume at a certain frequency and intensity that you're not going to have heat buildup, which is not necessarily true. What makes a non-thermal treatment non-thermal is blood flow. Vascular tissue that has adequate blood flow is not going to heat up. It's going to have minuscule heat rise. The energy being delivered is still causing kinetic energy, so the kinetic energy is still being delivered, but there's not enough of it, and the vascular flow is keeping it down at a level that's considered non-thermal. So the idea there is don't treat any area that's avascular. So ultrasound can cause heat on any setting at all if it's put over non-vascular tissue. So there's certain tissues of your body that you should never ultrasound anyway because it can't dissipate heat. It doesn't safely absorb and dissipate the way it should. And that's the reason various people have documented, don't call it non-thermal, call it mechanical, call it, subthermal in most tissue. So basically realize that even at a 20% duty cycle, yes, on vascular tissues, human tissue that has blood flowing through it, it's not likely to cause a heat rise, but all tissue is not created equal. For example, around a black toe, if somebody has severe arterial damage, ultrasound is not a modality that you should be putting on in any form, simply because the blood flow is so impaired, you can't predict how evenly that energy is going to be distributed and if they can dissipate it well. So again, think about your precautions that way. So when they looked at why ultrasound works, the way I look at it is sort of this acoustic energy, this vibration is shaking up the cells. Some researchers credit it to cavitation, the gas buildup causing bubbles that vibrate, and that vibration at a level that's not high enough and frequent enough to heat it, but enough to just oscillate it and shake it. When I teach edema management, one of my slides, I probably will put a copy of this in here, but one of the slides shows the idea of one cell connected to another. So when you think about, you said you do lymphatics, right? So when you think about this soft tissue and how it connects to a blood vessel or a lymphatic vessel, there's a connection. All of our cells are connected or we just fall apart. And so when you think about the connection and the pulling of those tissues back and forth, that can create inherent physiological benefit. There are things that it can do. So when you think about that vibration, that's what a lot of the benefit is being credited to, is the simple act of vibrating those tissues. And the energy can be absorbed more by some tissues than others. We already talked about that. So there is an effect of this vibration on the cell membrane. There's an increased cell membrane permeability. And when you think about everything goes back to the cell. Everything about your body's ability to heal, tissue that's capable of replicating, it's the cells that have to replicate. And so when you go back and then you think about the individual cells of the tissue, there's an increased cell membrane permeability, there's an increased local histamine response. That's another common thing is when I often will ask people, why are you doing the ultrasound here? Many people are under the mistaken impression that ultrasound is an anti-inflammatory. It's not. It's more, I mean, if you had to categorize it as anti-inflammatory or pro-inflammatory, it's pro-inflammatory. It increases the local histamine. I think inflammation has a bad reputation though. I mean, when you think about it, if we go out there in the lobby and we interview a bunch of people and say, is inflammation good or is inflammation bad? Don't you think most non-medical people are going to say inflammation is bad? It's got a bad reputation right now. Well, it probably always has. But we know that inflammation, normal healing inflammation is a good thing. I think more and more people are getting on realizing that inflammation that is effective and takes you through the stages of healing is necessary and appropriate. We need that. A lot of our patients don't go through that. Think about the people who are always on steroids. They're always on anti-inflammatory, and so their healing process is stifled. Think about the people with diabetes, and they have peripheral neuropathy. Autonomic peripheral neuropathy, the tissue doesn't know it needs to heal. It doesn't know when it gets injured. It doesn't know to move into the next phase. So this is where our modalities might be of help, of benefit, is stimulating some of those processes to happen. Ultrasound has been found to basically heal up, promote healing. Okay, so histamine. There's an increased vascular permeability, so you'll have increased blood flow even without heat. There's an increased local inflammatory response. There's also an increased macrophage activity. You guys remember macrophages? A lot of people thought of them as Pac-Man. They're more amoeba-like. They come into the area. They are a chemical mediator. So they migrate into the area. They engulf bacteria and debris, and they help clean up the area. But they themselves are also chemical mediators that release additional enzymes, which will help move the tissue on to the next stage. And so it not only does what it's supposed to do, but it spurs other chemical reactions to happen that promote healing. Ultrasound has been found to increase fibroblast activity. Fibroblasts are going to lay down new tissue. They're capable of producing new tissue, increasing the amount of protein synthesized in the area. So when you think about the tissue we're trying to heal, typically tendons, ligaments, muscle tissue, we need all those things when it's damaged, and it's going to promote those things to happen. Enhanced angiogenesis, that's just some new blood vessels. So anytime there's damaged tissue, you lose some blood vessels. Angiogenesis is the production of new capillary formation, new blood vessels, which you're going to need. That's a subject of a lot of debate because peripheral vascular disease is such a common problem. And that's found to be enhanced wound contraction. So wound contraction is basically when you look at how wounds heal, there are specialized cells called myofibroblasts. And the myofibroblasts, basically think of it as we all hold hands and we pull in. That's the idea, is they attach to each other, they attach to the surrounding tissue, and then they shrink in size. So they're fibroblasts, but they have, the myo means muscle. They have the ability to contract and get smaller. So that's going to make any injury and defect smaller. Wound contraction is considered a measure of wound healing. And so you'll see that. You see that in open wounds that heal very obviously. Okay, so when you put it all together, you know, all of these characteristics together, it basically amounts to wound healing, tissue healing. And so that's what you're looking at, is even without heat production, you can take damaged tissue, which you may not want to increase blood flow anyway. I mean, the reality is you may not want to, I shouldn't say blood flow, you may not want to heat this type of vulnerable tissue anyway. So these are the ones where you want to promote healing, but you don't want to promote heat. Those are the ones you would use this non-thermal effect on. Okay, questions?
So if you're using thermal effects at thermal level, you're still going to have all these.
Yes,
right?
Very good point, is even with thermal, you get non-thermal. So the question here, I shouldn't say nominal. See, that was a really wrong statement. Even with thermal, you get the mechanical effects. So you're getting the physical vibrations. It's whether you're getting them rapidly enough and aggressively enough to build up heat in the tissue at any given time.
Can I ask you a question?
Sure.
Because this seems to be the basis of a lot of disbelief that, that this works.
Right.
And so how was this proven? And what are we doing in terms of proving this again through
Right.
more studies?
Right. Where are you hearing the controversy? Just everywhere you just
From
read
other
it?
therapists.
Yeah.
But also when we've done meta-analysis and
Right.
tried to pull in, we don't have it,
Yeah.
it's not there.
Yeah.
There might be
There-
one study,
Right,
but it's not
exactly. There's
backed up.
not,
so to
So-
say this is fact, that
Yeah.
macrophages are actually enhanced,
yeah.
we're not finding it.
Well, there are studies that show it. Most of them
Now,
are
maybe
lab
someone will provide us
studies.
with that.
Oh, absolutely, absolutely. Most of them are lab studies. And a lot of them are on wound care. That's how I came across them, is because they were done specifically about cutaneous wounds and looking at cell replication and healing open wounds. Again, is it enough evidence to get reimbursed? No. I mean, probably not, because, to be honest, Medicare hasn't looked at it. You know, third-party payers really haven't looked at this so specifically. What I also look at is, and we can look at these things and communicate, is a lot of the studies we could argue were poorly designed. And I would look at it and say, well, gosh, no wonder their outcomes weren't good. It was either the choice of the patient wasn't a good choice, or the manner in which they delivered it wasn't what the previous studies had found were likely to work. So yes, there is a lot of controversy, and as a matter of fact, I'm trying to think if it was how many years ago it was that they did the you know, the debate when they have the national conferences? I can't think what it's called, but they have the round table and they have the two teams. They actually argued back and forth whether our modalities were, whether we should keep them or not. I can't remember the exact terminology they used for the debate, but they put in their ultrasound and stim together, which I thought was wrong, because there's such a huge difference in the amount of research that there is to show these things. But they combined the two and they had them all in there together, which, but in the end, they argued their case. So even in that, they had various research that they presented as to why, yes, we should use these modalities and they should be reimbursable and they do work, even though nobody's researching it. I mean, have you seen any really recent research studies looking at these subjects?
And a lot of the research is not solely ultrasound. You look at the research and it's ultrasound and exercise.
Yes,
So,
not well controlled.
So when you get to the non-thermal effect, there's really nothing out there that's going to say, okay,
It's absolutely
prove it.
proven, yeah. No, I agree with you, I do agree.
And the reason we did this, because we have one particular doctor that sends a patient, no exercise, ultrasound, all zones, whatever that means, shoulder. And we're like,
All zones?
all zones, ultrasound, all zones, shoulder.
Okay, so
And
does
we
this,
sit there trying, and we keep sending them the lack of science
Yeah.
behind this. And we refuse not to do exercise or joint molds or
Right.
really treat, so,
that's interesting.
oh yeah,
I've never heard
it's,
that before.
it's a challenge.
Yeah.
I understand why he wouldn't want the exercise unless he was doing a study.
Please, we've been,
Yeah,
but that's how we got onto this.
So,
Well,
yeah.
let's prove
Yeah.
where
yeah,
nothing has
let's
been done to
communicate, because I
show.
do have some I'll send you. Well, you're still gonna wanna disprove this, doctor, so that you
Oh,
don't
of
have
course,
to
and
treat
we're
all
always
these
gonna
zones.
do exercise, that's what we do, and we're always gonna do joint molds.
Right.
But on the other hand, you know, we do constantly look at this ultrasound question of
Yeah.
the non-thermal
The non-thermal
and-
effects. The one area where I think the evidence is being looked at the most is with low frequency ultrasound. And that's simply because in the wound care realm, it is a it's something that there are companies out there that are financially motivated to do the research. Is it directly comparable? They're using what they call long wave or low frequency ultrasound. They're using it in the range of 20 to 25 kilohertz. But that's the growing area where they're using ultrasound at a level that's not thermal, and they're using it in a way that is showing definite cell activity and tissue growth, and that is an area where if you want to try to compare, it is sort of apples and oranges because of the frequency. As of recent, that's the most common ones that I've seen that were well proven. But there's definitely some out there, and I'll pull them out and we'll talk about it. And maybe I'll pull a couple up today because I've got some on my computer, just to talk about the results. And I do think probably a lot of treatments that are done out there are not effective. You know, I think the majority of ultrasound treatments, if the therapist is not thinking about the target, they're not thinking about why they're doing it, they're not, you know what I mean? I'm not sure they're probably getting any benefit. I'm curious what the doctor's motivation is, because sometimes there may be something that they are reading that they think there's going to be benefit, but we just don't know what they're talking about. You know what I mean?
They
Oh,
don't
you
either.
asked?
They don't either.
Okay, all right, so we'll come back to this.
I've had the opposite years ago, is a doctor that I wanted to do ultrasound, and he said, no, he was an orthopedic surgeon. He said, because when I open patients, it's like if you thaw chicken in the microwave, parts of it will cook. He finds cooked tissue, and he believes that it's from therapists jacking up the ultrasound and not using it appropriately,
I
not moving it
can't
around.
imagine that that's happening, but wow, yeah.
He didn't cite any references, but that was his personal reason for
His
not
personal
ordering it.
experience, which I wouldn't discount somebody's personal experience, but I would find it hard to believe that somebody who has sensation, that you would be capable of damaging their muscle to the extent that he's describing without them running out of the, you know what I mean? They would withdraw. So I do
He
think
says it
patient
cooks the
selection,
tissue.
yeah.
How hot would it have to be to cook tissue? 115?
Well,
He said.
it would have to be well over the pain threshold to cook the tissue, and whether it could possibly damage it, not if you pick your patient accordingly and if they have sensation. I do think if your patient selection is appropriate, you're not going to harm anybody. The potential is there, but you're not going to do it because you're going to be a good advocate. I do think a lot of people out there, a lot of therapists, they are busy. Some of us talked about this yesterday afternoon. The requirements of the volume and the amount of time you get to stop and really think about what you're doing could put us in dangerous situations because we don't have adequate time to really reflect on what's going on. So I do think, not necessarily with ultrasound, but with anything, the choices could put somebody in harm's way if we don't have time to think
Can aides
about
or
it.
assistants do the modality
No.
in Florida?
No. Can aides or assistants? No. I mean, ultrasound
We
is
used
a,
to be able to.
Assistants can.
oh, it's like a PT assistant or a COTA.
Assistant
Yes,
can.
absolutely. An
Tech,
aide,
no.
a tech, a non-licensed individual, no. So a non-licensed person. I mistook that word, yes. And that's where, I don't know if that's being done. I don't know of any physical therapy, occupational therapy clinics that are delegating it to non-licensed individuals. But I hear a lot about other clinics that are,
And
other,
laser treatment is delegated to non-licensed people too, so like that.
that I don't know, but I'm not gonna, we're not gonna
Yeah, that's a
tangent
whole
there.
issue.
Okay, do you guys need a break? You wanna take a 10-minute break? Yep, let's do 10 minutes. So according to my, it's 10 till 10. So let's take a break. Yeah, so.
I have a question, Jamie. Has anyone ever looked at, if you go into a thermal effect
Mhm.
and you want to get DP to ligaments and tendons,
Mhm.
why not just put them on a UVE or exercise equipment and warm them up? And is the warm up, which is what I mean, I'm not a big advocate of ultrasound.
Yeah.
If I use it once a year, it's probably a lot so
Yeah.
far, because I've gotten further and further, and I did wound care a lot, so I see the, but I need to know this actually works.
Right.
Okay, so my feeling is, has anyone actually looked at the research at the cellular level of just heating through exercise and compared it to the ultrasound heating? And if it's the same, then why are we doing this?
Right. No, I agree with you. I think ultrasound in some sense I mean, I work in a neuro facility. I rarely do ultrasound either, but when I do, it's for heat stretch
Yeah, exactly.
purpose, simply because that's the need, that's the patient population I treat. But could it heal tissue? Is a good question, I think, especially with the diabetic population. And given the research on, mostly done by MIST, the company Acceleration that makes MIST, some of their evidence is kind of compelling, especially with the diabetic population, where they weren't going through the phases of healing, and they were able to stimulate. And it makes you, why? You know what I mean? It's so hard to prove why, if it's the enzymes, if it's the cell activity, the
See, but in most you
vibration.
can see the benefits.
You can,
You
outside
treat
of
without, you treat with your typical chemicals and agents you use, and then you do the one with the same protocol, and you add the ultrasound, and you do the time comparison, and you
Right.
get your enough ends, you get your number,
Right.
you prove it. But with us,
Yeah.
I'm
So-
a hand therapist, and I tell my patients, we're gonna try this, I'm not sure it's gonna work.
Yeah.
So how many times we do this will depend on how it feels. And, I mean, whether it's a placebo effect or not, people do say they feel better after the treatment.
Yeah.
Lateral epicondylitis, Decker veins, trigger finger,
Mhm.
those are the main people that I use that for.
So I encounter a lot of people in this type of setting who say the same thing. They feel, when it comes to the exact same type of thing. So if you look at the research and you look at, right now, if you look at statements, the broad statements from meta-analysis, that was what I was looking for yesterday, I couldn't find. The broad statements from there is that no, it doesn't work for medial lateral epicondylitis. The jury has decided that there's just not enough evidence. However, when you encounter people who firsthand treat people on a day in and day out basis, they claim it does. And we've had many of these same discussions, because I'm a skeptic too about most things. We don't have a lot of time with our patients, I want to make it count. And I think the majority of treatments out there are being done because you can get paid for them, not because they work. I think, unfortunately, the majority of, I shouldn't say majority, there are a lot of people out there who are tailoring their treatments around what can I get paid for.
exactly.
You know? And so we talked yesterday about some modalities that many of us have used over the years that we love and we think are very effective. But we don't use them.
Yeah, and I'm
Yeah.
not of alternative medicine. I mean, I trained in
Oh, but these things aren't
don't
even,
get to do
yeah,
it.
they're not even
So I
alternative, they're
agree
too
with Karen,
expensive.
if the patient says he feels better, and whether it's a placebo effect
Mhm.
is fine.
Right.
But then my skeptic side says, well, that's 5 minutes of wasted time, or
Right.
7 minutes, and,
What could I have
what
done?
could
So
I
I
have
like
done? I mean,
that whole placebo effect thing though, because you wouldn't get that effect if you didn't do it in the
Right,
first
I like
place.
that too.
So it's still a benefit, even if it is placebo, they get
Yeah,
a benefit.
it's
But
really
could I
They
use
wouldn't
a
get.
spoon? Could I use a spoon instead of having this device
Then
that I
you
have
look
to
silly
manufacture?
using a
What's
spoon.
that?
You just look silly using a spoon.
Well, if they
You gotta
couldn't see
convince
you,
them.
if they couldn't
Right.
see you.
So
Yeah.
there was this great paper that I read back in PT school, and it was basically this guy was reviewing ultrasound studies, and he said all these people are, they're putting up ultrasound versus sham ultrasound, but really they weren't doing it right, like you said.
Yeah.
So he's like, really, they're putting up sham versus sham, so no, they're not gonna see a difference.
Yeah,
Because they were doing too big of an area, their parameters weren't right, like everything you said.
yeah.
So
I didn't bring any of my books with me, but I have a number of textbooks at home that I've got all my little things sticking out of, and there's little notes on them. This is the section that I refer people to when they ask about, because this kind of question doesn't come up as often as I would like it to, because I think it's a really good discussion to have. But there are, the ones that I have found, those rare, really interesting, good studies or statements that I'm like, that's a good one right there. And it's like what you were talking about.
But
you know?
again, you could pick any textbook, it's
Right.
still gonna be based on the research studies quoted in the back. And when
Well,
you pull
yes.
these research studies, very small ends,
Right.
very,
No, but these are
questionable
textbooks
treatment
related to them
methods.
where they've worded it in a way. There's a couple of authors that I think are very, like they're very skeptical, and they are definitely taking the evidence and criticizing it. And they're saying, here's what shows that it might work. And actually, I don't know if you went on that electrotherapy on the web. I feel like that site also does a very similar thing, and it talks about the type of energy and how it can be deposited, and how even two similar treatments, but not delivered over the same exact type of tissue that needed the treatment, would have a different outcome. And skin is not the same as a tendon. I agree. And there were some studies on animal models, and they're not new by any means, but they did, some of them received ultrasound and some did not, and then they actually removed the tendon and compared it under microscope. And I think those are really interesting studies too, because they find that from a healing standpoint, the quality of the tissue is of different quality. And there's not enough of those. I think there's just not enough money or time or interest for people to
Yeah,
do
and
that.
that's what it is. It's, well, electricity for one. What are you gonna get, electricity is free, comes out of the wall.
Yeah.
So is anyone gonna really put a lot of money in something that they're not gonna make money off of? What, no, they're gonna make money off of pharmaceutical studies.
I don't remember if I said this yesterday or somewhere last week, but I said what's driving manufacturers and evidence is unfortunately not clinical outcomes most of the time. It's how can we make money off of this? I mean, we invent stuff every day at work. Because we wanted, this week, I'll give you an example, this week we needed a weighted walker for an ataxic patient. And I'm looking online for weighted walkers, and they're like $500 to $700. So you know there's weighted poles? We just we taped them to every possible pole on the walker, and we made our own weighted walker, and I said, we should really make these and market them where we can put these poles in, and I
That's
can
what
make it
we
for far less than $500.
We actually need a patent lawyer more than we need.
Yes,
I think.
because we have these ideas, and when I teach wound care, I go the craziest. Because I start thinking of all these things that I can't invent. I can't change the way the ultrasound machine works. I could call people and talk to them about it, but for me to all of a sudden have one that's created that could do what I kind of want it to do, it's impossible. I'm not going to be able to. And to be honest, I'm out here teaching a course that is, there's a need basis for it. The course, that's why I'm teaching ultrasound, is because that's the one that the OTs in the state of Florida have to have the 4 hours of training to do. So to say that I'm innocent in the process is not necessarily true, but it's fun. I mean, I think these are the things that are interesting to talk about, because I agree that what are they using it? Are people using non-dermal in clinics? Are you using non-dermal?
You are. I do that mostly.
Yeah.
There.
I have to say, when I do use it, I usually use more thermal levels. I mean, am I using it aggressively thermally? Not really, but I'm using it more for the thermal benefit of heat and stretch to try to increase
I
range of
actually
motion.
have been using the 50-50, the 50% more.
Yeah, 'cause
than 20%.
Yeah, my thought
So
there
I
is, it's
get-
not well proven, is anything, you know what I mean, as you're pointing
Yeah,
out.
I mean, honestly, the only time I use it is on the stretch when I go fasciitis. It's the only time I use it. I don't use it.
But you're using it for epicondylitis.
Yeah, but I'm also doing stretching
Yeah.
during the treatment, so I do a little bit of stretch, any of my
Yeah.
tendon problems.
Are we, is it time? Because this conversation can continue to go on. I think it's an interesting one, but I had a therapist at one of my courses a while ago who always used, I don't get a lot of tennis elbow or golfer's elbow or whatever, the medial lateral condylitis, but he said he finds that, and I have found this to be true in this environment, is that people have a trigger point. They generally have a trigger point in probably their extensor carpal radialis, or, and that they found that if they treated it with thermal levels of ultrasound with stretch, they had significantly better outcomes than did they not incorporate the the ultrasound.
Right.
But that led me to the question, could you do E-stim point stimulation as well? And so this person said, I'm gonna try it, because he happened to see a lot of that diagnosis and I don't. He never contacted me and let me know, but he was gonna try a little
I'm
comparison.
gonna try that.
So, will you contact me and let me
Yes.
know?
Yes,
Because that way I can say,
Yeah, and that's what we do a lot more. of,
under
the point-
follow-up.
The point stimulation.
Well, my curiosity would be, would 10 seconds, 20 seconds of point stimulation offer a similar benefit of spasm reduction, trigger point reduction, combined with the stretch, use the range of motion? Could you possibly have the same outcome in a more efficient manner? And some people would say, sadly, the question I might get, well, how would I get paid for a 10-second treatment? But if I did 8 minutes of ultrasound, I could get paid. I'm like, well, that's where our billing aspect needs to change and make us as efficient and effective as possible, unrelated to the reimbursement. Because then we would use the modality we were talking about yesterday. If it gets them better, faster, and we get better outcomes and our population demands it, we're gonna use what works rather than what I can get paid for.
Yeah, and to preface that, that's the beauty of where we are. We're in the VA. I don't have to worry.
Oh, I meant to ask you, do you know people in the VA around? Becky
Miami,
Rich,
of
do you know
course.
Becky Rich in the Orlando? No, okay.
No.
She was my very
Jacksonville,
first
I know.
supervising PT ever when I got out of school, and she taught me so much. A lot of it I did not know how indebted I would be to her until I reflected back on it. Because I remember thinking, she's so slow, we would be talking about something and there would be this. And I was just like, I'm like, let's go. And I look back and I think, oh gosh, just what a smart, you know what I mean? I learned a lot about, think about what you're doing. You know what I mean?
Inpatient.
Right now she's inpatient at the VA, in Orlando. I guess there's a brand new
Yes,
VA facility. I've never been there.
Yeah.
Yeah. I think they went from a really not nice one to a really, really nice
Yeah.
one.
Oh, it's incredible.
It's Lake Nona, right?
Yeah.
Lake Nona, I believe is where, yeah. See, I live way on the other side of Orlando because she actually contacted me and I looked at a job there, but just way too far of a daily commute for me, so. But they do have the latitude, she
You don't have to worry
describes.
about reimbursement and treatment.
That's true.
I'm hoping that the making retirement home for veterans in Port St. Lucie.
I'm sorry, say that again?
The building a retirement home for veterans in Port St. Lucie, the VA is. So I hope I'm still in the area by the time they get it done. I would love to work for the VA.
We're out of tradition. that
Yeah.
in the West.
Mhm.
Okay, so let's talk about contraindications. This is another one that, as we talked about with E-STEM, a lot of it is debatable. It is really debatable because there's the theory that it's bad for you, or that could harm something, but there's not necessarily documented cases of someone getting injured in this way. But my number one, and it's not even on this list, my number one thing is don't ultrasound something you don't know, you don't understand. So strictly stick to the musculoskeletal system, the connective tissue, your skin. Treat what you know. So don't treat somebody's internal organs. Don't treat somebody's abdomen in a way that it could travel through tissues that you don't know and you don't understand. So stick to what you know. Stay within your area of expertise. I wouldn't want to ultrasound a growing fetus. I don't think about the production of cells in that. So you don't want to affect a growing fetus, so avoid the possibility of that. Now, could I, with the ultrasound that I deliver, if I'm doing an ultrasound on someone's low back, could it get to their fetus? I seriously doubt it. But do I ever want to be in a court of law on somebody who had a baby that had a deformity of some kind and have to defend myself that I made that choice? So, as luck would have it, I don't ever treat pregnant people. It just doesn't happen. And so I don't ever have to be put to that test of questioning it, but no, I would not. I would not ultrasound over the low back above the pelvis, below the ribs, or anywhere in this vicinity of someone who is or could be pregnant. Don't ultrasound the eyeball. I know that seems obvious, but don't ultrasound, and I say the genitals simply because, again, I see these things in manufacturers' books and in textbooks, and I just think I should say it. But any kind of reproductive organ or
Well, they do use ultrasound on it, on genitals.
Mhm.
Just we don't, so, yeah.
We don't, right.
We don't.
So stick to what you know, again. The heart, you couldn't get to the heart if you wanted to, if, basically you could ultrasound over someone's chest wall and it's not gonna penetrate past the bony fascial layer here. And actually the way they look at a heart is either esophageal down through the esophagus or below the ribs and up. So again, stick to what you know. Ultrasound the musculoskeletal system in the chest wall is fine. Pacemaker, any implant, basically any artificial implant should not be your target. I've had people ask about various things over the years that could be implanted. You know, I had someone ask about breast implants. I've had people ask about, you know, just various things that might be in somebody's body. Stick to what you know. Of course, I'm not going to ultrasound over anything that is artificial, where I don't know what's going to happen if I were to, I don't know what could happen, so I'm not going to do it. Malignant tissue or any abnormal growth, so if it's something that could be potentially malignant, it's, you know, something abnormal, don't ultrasound over it. Ischemic area, the worse the blood flow is, the less predictable it becomes what's ultrasound going to do when it encounters this tissue. So it could heat up faster, it could cause harm. So I wouldn't do any ultrasound, even on the settings that are designed to be non-thermal. I wouldn't do any if they have very impaired blood flow. So again, back to the idea that the black toe and the tissue around the area, I wouldn't, it has such impaired blood flow, you don't want to do anything that could harm it. It's not capable of dissipating. A little bit of energy could be harmful. If they have sensory impairment, I mean, here's the thing, is a lot of people have some blood flow issues. You know, PVD, peripheral vascular disease, is a very, very common diagnosis that you're going to run into. Sensory impairment, neuropathy, especially in a diabetic population, it's very common. A combination of impaired blood flow and impaired sensation would be an absolute, just don't do it. Don't do any ultrasound at all. Now, if they have some blood flow issues, meaning they have a diagnosis of peripheral vascular disease, but they have good sensation, you've tested their sensation, their sensation is not impaired, arguably you could do ultrasound. You know, it would be precaution, I would be cautious, but their safety net is there. They could say ouch if it gets too hot. That's why when the doctor talked about the severe damage to a muscle, it's just hard for me to imagine that could happen. I mean, I don't want to say it's impossible, I don't know what he saw, but it just seems very, very unlikely you could ever harm somebody, assuming they have good sensation. Adequate sensation is going to cause you to, I mean, we're going to do ultrasound on each other during the lab, and as soon as it gets uncomfortable, you will reflexively pull away if it hurts. So assuming that this patient had blood flow and had sensation, it's hard to imagine they could get damaged muscle. But okay, so if they have good sensation but impaired blood flow, it's not that you can't do it. You've got to weigh benefit risk and think, is it worth, you know, is it worth the risk, and consider the risk. If they have impaired sensation but good blood flow, I would not do anything that could be in the thermal range, but you conservatively could maybe do something at a 20% duty cycle. In that way, if they have good blood flow, it's very unlikely they're going to have any heat buildup. But again, it would be a proceed with caution, and I'd say benefit risk. Is it worth it? Thrombus, thrombophlebitis, any kind of a blood flow impairment. Again, back to what we talked about yesterday with ultrasound, you will alter blood flow, and you could, if there's a clot and they're not cleared for you to do exercise, don't do ultrasound either. Infection or abscess. You know, it's interesting because the new, it's not really that new, but the designed products that are being used for wound care, that are specifically for wound care, are being used purposefully on infected wounds. So it is an interesting thing that they find it acts as an antimicrobial when it comes to open wounds, but that's very different. So if you have an abscess, ultrasound is not recommended. So an infection in that way, it's not recommended. Epiphysis of growing bone. I mean, I'm a star next to it because again, I haven't really treated growing children, and I haven't seen any new research on this, but older research showed danger, hazard, that it could harm the epiphyseal growth plates. But, you know, those studies that I've looked at, and this has been a long time, they use very high levels of ultrasound. Nothing that you would actually use clinically. I mean, if you're using the levels that we're going to be talking about, this is not what they used. So it doesn't mean you can't treat children or anyone who's growing, a growing child.
I have a question.
Sure.
Aren't bone stimulators,
They are ultrasound.
they're
yeah.
ultrasound?
Yeah.
Because my son broke his wrist when he was 15, and the doctor ordered a bone stimulator, and I researched it, and I said, no, you know, I'm not putting a bone stimulator on his open growth plates.
So he had a fracture in the area of
In the
growth
growth plate, yeah.
I don't
And
blame you
through the
there.
growth plate.
Without further research, I wouldn't have done that. I
Right.
wouldn't have done it either. But, right, so, but to translate that to, you can't treat someone who has growing bone isn't necessarily true if you can treat an area that isn't near the growth plate.
Right.
But it would be interesting, I don't know if the studies that have been done on bone healing were done on children, on young people. And you gotta wonder, was he not healed?
Yeah.
I don't, you know what I mean?
Yeah.
It's like, usually when I see it, it's because it's an older person
Mm.
with a probability of poor healing. That's
Yeah.
usually when I see the bone stimulators, is they think that there's a likelihood that they're gonna have a
Yeah,
problem healing.
I was a little surprised at how aggressive this orthopedic guy was, so.
Interesting. So basically, yeah, I mean, epiphyseal growth plates, I haven't seen any new studies that looked at that as to whether it, in certain levels, still are considered harmful or not. I don't know. But right now, because we don't have proof and there is some evidence that it could be harmful, I would avoid it. So avoid open growth plates, but that doesn't mean you can't treat kids. You just have to make sure you're not directly over that target. Undiagnosed pain, especially with a history of malignancy, I mean, that would apply to anybody, just treating them in general. If they come to you and you don't know what's causing their pain, my question would be, how could I possibly treat them effectively if I don't know even what's going on?
What are you treating?
Right, what are you treating, what are you doing? So again, I aim that more at folks who possibly say, well, let's pull out the ultrasound and let's just see if we can make you feel better. I wouldn't do that. And then stay with your area of expertise. That's just another thing to stick with what you know. Just because I said that this morning, just because I can doesn't mean I should. Just because I am licensed and legally allowed to do something, it doesn't mean I should if I'm not experienced or qualified to do it. When in doubt, get a second opinion. I do think, again, PTAs, COTAs who didn't evaluate a patient, if the evaluation, the plan of care directs you to do ultrasound in some way and it doesn't make sense to you, go back and ask them why you want me to do it so you can better understand what's the purpose of it. And again, they shouldn't be insulted. I do think sometimes it can be tricky to manage that relationship, but I would certainly never be upset with somebody who came to me and said, I want to understand what I'm doing with the ultrasound so I can make sure I'm doing it properly. If I look back and said, you know, now that I think of it, I don't think we should be doing it, I would be grateful rather than upset. Precautions. So, you know, again, the idea of contraindications and precautions can be a little gray as to whether it becomes a contraindication if the benefit doesn't outweigh the risk. This first one, increase in symptoms or improvement not as expected, is just it's kind of a generic one that I have a lot of people who will say, well, how many treatments can I do? Well, it's very unique to the individual and the diagnosis that you're treating, or the symptoms, the area. My thought is, if you're trying to increase range of motion, and their range of motion has decreased, I'd go back and think about what am I doing and why am I doing it, and why would I do it again? If you're trying to promote healing, and they seem worse, or their symptoms are worse, or if you're trying to relieve pain and their pain is worse, again, I would not keep repeating that. If outcome improvement is not as expected, you know, a good example in my mind would be, let's say you're trying to heat and stretch, increase range of motion, and this is someone who has a musculoskeletal problem, they're normal from a neuromuscular standpoint, and you do ultrasound, I would expect to see an improvement pretty much every time. You know what I mean? It's not that complicated. I would expect that soft tissue to get increase in the range of motion every single time I treat them. Now let's say that that person is not neurologically intact. Let's say they have high tone. So you're kind of fighting an uphill battle. You're trying to increase range of motion on someone that's more difficult and more complicated. I may not measure every day. I may measure once a week and expect to see improvements rather than every single day. So the more complicated the person becomes, the easier it is for me to document this improvement is significant given the complicating factors of high tone, difficult positioning, poor compliance, whatever things I can justify it with would help justify the longer treatment, the more attempts at treatment. Versus someone who maybe let's say somebody has a wound, an open wound that's been present for months. I would give it longer. It's harder to quantify if you're seeing improvement in that way. And what you describe, it's somebody who has an injury that you're trying to help it heal. How do you quantify that it worked? It's really difficult to do. And so I might keep trying from a clinical perspective in order to say this person had a poor prognosis for healing, and the fact that they did heal ultimately was proof in my book that it helped. But again, it is hard to quantify. It's hard to put that in just words, you know. Okay, so that's the idea of symptoms getting worse or not being as anticipated. Overfracture size is what you just talked about. I don't know how new it is, because I know when I first graduated in the very early 90s, in 91, patients would sometimes have an electrical bone stimulator. And they wore it for hours and hours a day. I think it was in the range of 6 hours a day or something like that. It was a long period of time. Now ultrasound is generally what's recommended for a non-union or for a poor prognosis for healing. And it's worn for a much shorter period of time. So what was once, when I learned in school, was a contraindication, was overfracture site. You could not do it, you should not do it, right. Is now an actual indication. I don't know that they're actually being sent to physical therapists or occupational therapists for this purpose. I think it's simply a modality that's being used. So if you had a patient who had a fracture and you want to do ultrasound in that region, it's not contraindicated. I'm not sure why you would do it if it's not for the purpose of bone stimulation, but it's not contraindicated. I would just be cautious and understand what you're doing and why you're doing it. Open wounds. So actually ultrasound in various forms is used specifically for the purpose of stimulating healing. Right now it's really moved towards low frequency ultrasound, and it's being pretty heavily promoted from a marketing perspective. But it is used, and there is a fairly good amount of evidence on the websites of these companies. So it is used for open wounds, but you know, when you're going to treat wounds, if you're not familiar, don't just think, because I know how these modalities work, I'm going to treat wounds. You have to also very well understand wound care and make sure that good wound care is being done. Decreased cognition, I mean, this is a very generic one as well. If you can communicate to a patient, if they can communicate with you, especially from a thermal perspective. Can you safely deliver it and have them let you know if it's uncomfortable, and you can do the treatment safely? Pregnancy, other than the abdomen or low back, I could lump that in with so many diagnoses where when you have a certain condition that is a temporary condition, or that could have all these side effects that could make your treatment more concerning, then you've got to consider that. So I don't treat pregnant women. I'm not a female specialist, so there's things that are going on in their body that I may not fully understand, but certainly joint laxity is one that I'm familiar with because I have been pregnant. I've had kids. So knowing what you're doing and why you're doing it during those conditions. I get more and more patients lately with diagnoses that I have to look up. Have you guys found that? Where you're like, boy, I don't know what I would have done before computers, because the ability to know what this is, I would have to call a doctor, and ask about what does this mean, and depend on this person to tell me what it means. But yeah, so any kind of condition that you don't fully understand and the ramifications, it's what it does to your body or to your certain tissues could either make this more of a caution or less of a caution, depending on understanding what is happening with their diagnosis. Impaired blood flow. So, you know, back to the previous thing, if they have impaired blood flow with good sensation, that is a precaution. Can you do it safely? What's the benefit? What's the risk? Why are you using it? Do they communicate well? You know, that's going to be my question to you, is do you feel like this is important enough that, you know, you should do this, and that you feel they can communicate with you that they won't get harmed in any way? And then vice versa would be sensory impairment with good blood flow might allow you to do a 20% duty cycle, which is not likely to cause heat, but again, with risk just in case they can't report pain and they do experience any pain. Over the spinal cord, especially after laminectomy, I mean, your spinal cord is very protected. Any area of the body where they have had surgery, my concern would be, what did they have done? Is there anything artificial in there? What target tissue are you choosing, and is it viable tissue? Is it sensory, good blood flow, and it's, actual human tissue versus
So-
their implant?
So ortho, like if they, total hip or even if a hip fracture,
Yeah, so let's say
probably
somebody
want to be
had,
cautious.
yeah, so let's say somebody had a knee replacement and you want to target one of their ligaments, or they had metal in their shoulder somewhere, and you want to target a ligament or a muscle or a tendon. The tendon or, the tissue of their body is your target. My question is, can you safely target that tissue and get benefit out of it? That would be my question to you, and where is the metal, or what's artificial and where is it, and can you safely target that tissue? Okay, so the target is their tissue, not the metal, and how's their sensation, how's their blood flow? It always goes back to those two as well. Hot spots or standing waves, this just goes back to the idea that it's non-uniform, and you gotta keep your head moving in a way that makes it as uniform as possible. Previous experience with ultrasound, I say this one because you might have someone who comes in and sees the ultrasound machine and says, ooh, I want that, I love that. And they don't really need it, you weren't planning to use it on them. Or it could be the opposite. It could be someone who you think it could be of value, they've had it in the past and they found it to be not helpful or ineffective. I know that there was a while where our elderly population had been educated by Medicare that you report fraud and abuse, and they may have been, I've had patients who were very, very questioning, what are we doing and why are we doing it, and making sure that their Medicare's getting their money's worth out of what you're doing, which kind of cool, but again, if they have previous experience with therapy in general or a modality in general, like ultrasound, they may be questioning its value and is it something you want to use. Did you have a question? Oh, okay. Coupling techniques, this is just basically, in my mind, it's usually just eliminating air. Just getting air out of the field between the head and the body and making sure that the ultrasound can enter their body is the best way possible. So the air transducer interface, any air in there is going to reflect the energy back. It's not going to enter. Coupling mediums. The ones that are designed and marketed for the purpose of ultrasound are designed not to let air bubbles form. So they're meant to be good coupling mediums. So you typically want to use something that's designed for that purpose. And I would recommend that. We're going to be using ultrasound gel today. They do make lotions that might be a better medium if you're going to follow up with massage, or if you're going to follow up. So what you're going to do after might dictate what you use. But whatever you use, it should have good transmission. You can always call your manufacturer or look, what does it say you can and cannot use with the ultrasound. But typically you want to think about not only protecting your machine, but is there something that I could use that could harm the patient, that might alter their sensation or drive a chemical into their body that could be harmful. So it should have good transmission. I would recommend just using products that are designed for the purpose of ultrasound. Viscosity, water is a good medium. You can use water in a bucket, and that could be a transmission media, but again, it's a little bit of a pain if you're not prepared and you need to get a bucket out and you need to couple. That it might add a little bit of time and less efficiency to your treatment if you weren't anticipating having to do that. And it doesn't have the viscosity. It'd be nice to be able to use water on a shoulder, but they probably can't hold their breath that long to let me do the ultrasound. So you need the viscosity, and the gels come in different, if you look at the different manufacturers, some of them are more viscous than others. I've had people tell me that they were taught you had to have at least, some number, like I was told you had to have at least a layer of 3 millimeters of gel or various things. I've never seen that I would say why you would, and to be honest, any gel I've ever used, there's no way I'm going to maintain a level that's going to stay there, because what you'll notice is when you put gel on or lotion, whichever you're using, as you start doing your ultrasound treatment, it starts to dissipate and move, and you end up with a mountain of gel around the edge instead of in the middle. So what I usually tell people is try to make sure you pick a sound head size over an area that is adequate. And I usually use some pressure. So let's say I was using this sound head on my forearm. For me, the gel is primarily to allow it to glide nicely and just keep it kind of smooth. So I'm going to put the head on here and I'm going to apply pressure. So now it's, you know what I mean, there's no air getting in. I'm kind of flattening the tissue. Now if you're somewhere where you can't do that, then you have to think about, is there air getting in the air pockets? So a hand or a finger, if I wanted to use something this big, a bucket really would be my best option because it's going to eliminate any air. It's going to be hard to do with gel. But you know, the smaller the area, the less similar the surfaces are, the less likely you're going to be able to get a good coupling of that tissue. A common mistake I see too is people going back and forth and letting air, you know, if you go back and forth and the air's going in every single time. So some of it's more your technique that could cause your machine to beep at you. Because sometimes what will happen is a lot of machines, they'll beep if it senses a lack of contact. And that's usually because the temperature of the ultrasound head starts going up and it beep, beep, beep. If that's happening, look at what you're doing and see if maybe you're not coupling properly or effectively.
Do most of the gels, are they okay for sensitive skin?
Yeah, they're primarily water. I've never heard of anyone having any kind of an altered reaction, but that could come a day. It could come a day.
Generally though?
Yeah,
Okay.
I'm just looking to see what it actually says on it. Yeah, no, it doesn't actually have all the ingredients, but my understanding is it's primarily water. That's a question I've never been asked, but I'll look what the ingredients are to just see is there anything. If the person has, if they say, I'm allergic to every lotion on earth, I'm allergic to pretty much everything, you know, that would be hard to, I'm surprised they're still alive. But regardless, if somebody tells you I'm very seriously allergic to things, if you can couple with water, I would. Until you find out, is there possibly anything in there? And in the meantime, I can look up the ingredients. I'm not aware of anything that's typically people are allergic to, but it could happen. Patient comfort is, a lot of people heat up their gels or lotion. It's been quite some years ago that I read that there was somebody went and did like an epidemiology kind of thing, and they cultured around the opening of the gels. And they found bacteria present, and they found it was worse when the gels had been heated than when they weren't, because it offered a really favorable environment for bacteria to grow. So a lot of people stopped heating them, but heating it or not heating it, think about the bacteria and infection control anyway. That should be something we're all concerned with in this day and age, especially if you're in an environment where you have primarily inpatients and they're immunocompromised in any way. You definitely need to consider that. I do think more and more people have gone away from the giant bolus of gel that you refill the containers. I know it's less environmentally friendly, but disposable, bottles that you throw away are more likely to be less contaminated. You can keep them, they're less likely to get contaminated over time than the ones you keep refilling again. And they actually, you can get individual, I have a couple of like Doppler size gel containers that are smaller, and you can get those. They're single use dispensers now, so if you're going in if you have certain people where you really need them to be sterile, they have individual sterile packets of gel. So there's things you can get. I think most of those are usually used in surgery, for diagnostic inside an open area, but they're available if you wanted to use it. So there's all different levels of keeping something for one person use. If you want to assign them a bottle or a small bottle, or dose it out before you go in so that you don't take a bottle and use it right next to a patient. Another thing along those lines is a lot of people ask me, should I put the gel on the patient or on the sound head? And I would say if you are using sort of a communal gel bottle, if you have a bottle that you're going to use on multiple people, then before you ever touch the patient, and while you're clean and non-contaminated, and so is the head, put the gel on the head, and then don't touch it again. And that way you're not going to be able to contaminate the bottle. So that you squirted it on here, and then you did your ultrasound. Now, if you decide you need more gel in the treatment, then you can they're going to contaminate the bottle. So, don't squirt it right on the patient is my recommendation. And don't think about your hands. The most likely place you're transmitting things is from your hands, from one place to another. Think about the area of the body to be treated. If it's, again, like a hand or a foot, and it's a difficult to couple area, it's gonna be more challenging. Bucket of water, lots of gel that is gonna be needed to create a layer that's not gonna let air in, versus a larger area where it's not reasonable for you to treat it in one session. Direct coupling is what most people do. I would say it's gel or lotion on the head, and you do it right on their body. Water immersion is certainly something that's a possibility, and bladder, you know, I've had people from time to time say they use, for example, a Ziploc bag filled with water. And what that can do is it takes an uneven surface. One side of the baggie is accommodating for the uneven surface, and then you have a layer of water, and then you have a smooth side on the top. It makes sense. Seems to me like a lot to go through. And even trying to accommodate for the uneven surfaces, the possibility of entering air into the system seems likely. Trapping air under one side of the baggie or in the baggie seems like a very real possibility. But using some sort of a bladder as a spacer is certainly a possibility. As if you take water in some way. Over the years, I've seen various products come out. I've seen ultrasound condom covers. Basically, they rolled on, and they were meant to offer infection control. And I remember thinking to myself, am I touching this and removing it, and everything is negating any benefit I would have gotten from this thing being over it anyway. I never understood the concept. I did think it was a kind of cool idea to take a condom type cover. If you picture a rubber tube that you would put over the head, and if that was filled with gel, that's kind of a cool idea. If you took a firm head that's flat and you kind of turned it into a conforming. So you said you do hand therapy, right? So it would be kind of cool to have sort of a bulbous, flexible head that you can move around. So the idea is cool. I don't really need the idea for where I work clinically, but it's kind of a neat idea. But again, I haven't seen those in a very long time, so I'm not even sure if they still make them. I know that I had several people who told me they used to put water in a glove, treatment glove, and then they would use it as a coupling medium, so I said, let's give it a try. So I took a glove, I filled it with water, we put it in a bucket. You can take your sound head, you can put it in a bucket of water, and you can see the ultrasound passing through. You can see it reflecting on the surface. And we stuck the glove in there, nothing came through. Now that was one particular type of glove, but it did not allow the ultrasound to even come through. So I said, just this glove, because this was at a private course at a facility. I wouldn't use these gloves because clearly the ultrasound's not even going through them anyway. And then I took one of my containers that had the e-stim electrodes in it, and we filled it with water, and we put it in, and I said, well, you see, that's what it should look like. So it went right through that baggie, through the water, and you could see it reflecting off the surface. And it seemed pretty unimpeded, but that was just to the naked eye. So the idea that if you're using any kind of a medium to allow you to better transmit, make sure it's actually doing that it's not somehow making it even less effective. They do make coupling discs. I see them mostly marketed for diagnostic purposes. They look like a rubber hockey puck. They're clear, and they're these flexible lumps, and they're meant to be used to sort of give space if they're trying to picture like a tumor or something. I've seen therapists have said they've used them. I don't know how I would use it, but again, as a hand therapist, there might be a reason why you would need a little space with a really, really nicely conductive medium. So those are out there. I don't have this on here, but I do want to talk about it. There are quite a few people I've encountered that have said they've either used Biofreeze or Sombra or something like that, some sort of a analgesic type product. I wouldn't recommend it myself as a coupling medium. I use those products a lot. I mean, they're great for a lot of my patients who have, especially nerve pain and things like that. It works quite effectively. But I wouldn't use it as a coupling medium for ultrasound. First of all, I don't even know I don't know how it might
like
impede
what's
it.
inside those gels, exactly.
Right, what the ingredients are, and if it could be harmful. And I don't see the benefit of ultrasound to go over it anyway, because where it works is on the skin, and the cutaneous nerve endings is what it actually needs to affect. So I don't see that there would be any benefit, because I've had people say, well, it would be like phosphoresis, and drive it in, get better deep pain relief. And I'm like, that doesn't really add up. I don't think It's,
That
it's
doesn't
not
make sense.
intended for that purpose. So my recommendation would be, don't use it as a coupling medium. Do your treatment with proven, safe methods, and then if you want to follow up with an application, then put it on after the fact. Did you want to say something?
Yeah, I was gonna say that I've seen them use it with the gel.
Yeah, I've heard people, a lot of people have told me that they do that. My feeling is,
I think it's like
why
just
would you? I wouldn't.
just like save a step, like get 2 in 1. You get the coupling medium and then they also get the benefit of biofreeze.
I hear what you're saying.
Something like that,
Here's-
just
here's
save it a
my-
step.
Yeah, here's my thought,
Right.
is I could alter their sensation while I'm doing a modality
This
that
is
I
true.
need their sensation for. You know what I mean?
Mhm.
So I take something that could maybe alter their sensation and they might not feel the heat I'm producing with the ultrasound. So I would recommend, and just in my mind, because I've debated this with people, I still stand that I would say I wouldn't do it because the saved that saved 1 minute you get, I don't think is worth the increased risk. I will say for a while there, BioFreeze, I know, had an ad that they showed it, but I've not seen that many years. But yeah, I wouldn't recommend it. I do like the products, I just wouldn't use it as a coupling medium personally. So that same ideas, moving along with phonophoresis, there are physicians that will order phonophoresis. I don't know if a lot of people are using it anymore. I don't think I've ever actually used it clinically on a patient simply because I've just never had the need or had an order to have to decide. Phonophoresis is similar to iontophoresis that we talked about. It's basically taking a topical medication that's capable of passing into your skin and ultrasounding over top of it. The theory is to try to get that drug to pass the skin and get to your target. So again, from a research perspective, I mean, I do agree that there's very limited, I have not seen really any evidence that backs it up very well. But I haven't studied every single one of them. I just think the theories behind it are that this is mechanical, it's physical, and that maybe it's gonna take that drug and push it a little bit further in and make it maybe get where it needs to, more of it, and get it more effective. The theory, you know, that theory makes sense. Or the vasodilation could allow it to absorb better. Now, in my mind, vasodilation could kind of channel
Move it
it
away.
somewhere else and move it away from the area. Or increase cell membrane permeability, allowing it to diffuse into the cell, maybe being used. Perhaps it makes the tissue more responsive to it. I mean, a lot of these theories kind of make sense, but I'm not convinced. I don't know. I don't know that they work. You got to think about the skin area over the area to be treated because, again, like yesterday I said, one of the common things they recommend things like this for is plantar fasciitis. And it's so thick and deep, the chance of a drug getting there through the skin just seems unlikely. It seems more likely for what you described as medial lateral epicondylitis. At least those targets seem a little bit more reachable, you know what I mean? So it seems more reasonable. But again, does it get there? I don't know, and I'm not sure that it does. And has there been any study where they did the ultrasound with the chemical, and then the sham? That's kind of what it would take. I used to think I wanted to be a researcher. And then I participated in a research study, and I realized, wow, boy, it's a lot of work for people to just punch holes in everything that you did. It's a lot of work, and there's a lot of criticism of studies.
And it's
I'm
very
guilty of criticizing them.
It's very scripted, and you have to do the exact same thing over
Right.
and over and over.
I'm not sure I'm cut out for
I
that.
can't
I'm a
do
little
that.
bit more of a
I'm an
fly by the seat of your
intuitive-
pants kind of person, yeah. No, I mean, I like the idea of it. I think I would enjoy it if I could do it.
I mean,
If I could just be one of the people and somebody else did all the hard work. And I did the fun stuff.
anecdotally, we used to use hydrocortisone on epicondylitis and bicipital tendonitis.
Okay.
And
I do think if
it
you
got
look-
good results, but I don't know if we would have gotten the same results without it.
Okay.
No.
So you used anti-inflammatory products over an area that was inflamed, or
Mhm.
theoretically that was
Yeah.
inflamed. And to me, I mean, again, this is a really good debate to have, is, to me, we just talked about how ultrasound is more of a pro-inflammatory, which again would argue, if you look back at, gosh, there was a really interesting study that was done where they basically said everything we're doing is not proven. You know, all these ultrasound treatments from a, you know, from a non-thermal perspective, they just aren't, there's no evidence for them. The evidence is so weak. And it talked about, they had done a survey and all these therapists were using it as for inflammatory conditions. And the criticism of it was, well, it's not an anti-inflammatory. But I think most of us would agree that a lot of the patients that come to us don't necessarily need an anti-inflammatory. They have more, instead of itis, it's osis. You know what I mean? They have tendinosis instead of tendinitis. They have, you know, and we could argue that therapeutically they could use inflammation, and maybe inflammation would be of benefit. Because you now hear about people, instead of injecting a steroid, they needle it, or they, you know, they put something in there to actually kind of traumatize it almost and put it into an inflammatory response in order to let it resolve. So they're forcing us to be a little more patient with resolution of conditions. So instead of stifling the inflammation, move it along and get it past the inflammation into, you know. So the whole argument of using an anti-inflammatory with a potentially pro-inflammatory modality causes me to want to think about that one. But it also makes me question what really helped. Was it just the ultrasound by itself? I don't know. I can't prove it. But I will tell you that's the most common thing that I think was ever used. If you look at what studies do exist, it's anti-inflammatories that were used. And I do think that modern day we are questioning anti-inflammatory use in general as a whole, whether it's orally, injected, in any way, that should we really be stopping inflammation the way they've been doing for many, many years. But yeah, from a perspective, I think that's what most people were doing, and maybe still are, especially if they have doctors sending them to ultrasound their zones. I love that. I love that. Okay, so think about the transmission media as well. So you described people mixing biofreeze with gel and using it as, you know, I do think there's people out there being their own chemist, you know, putting a drug into a gel and blah, blah, blah. You know, but the reality is, if you were going to do that, you just changed the makeup of the product anyway. You took if you had a 4% product, dexamethasone, and you mixed it with a bunch of gel, you just diluted it tremendously. So, I mean, I think, again, that idea is a potentially harmful one, that if you're doing that, how is there any control in what exactly you ended up with? So really, if you were going to do it and you really wanted to establish some sort of consistency, it would need to be done in a lab, and you'd have to have it actually, what's that word? You'd have to have somebody make it for you, or you'd have to you buy it at a proper dilution so that you at least have some control over how much drug is in contact with their skin. Either that, or you put it on their skin, allow it to penetrate, and maybe put a barrier over it, and then ultrasound over that. That way the drug itself is against the skin, and it's, you know, it's not being diluted. Yeah. I mean, again, if you're going to use it. Anybody using photopheresis or getting doctors sending you patients for that? Okay. So I hear the same thing. A lot of people just aren't doing it, but it's still an interesting thing that you'll read about, hear about. Pre-treating the area, and again, efficacy is not well proven. There's a lot of flawed research out there, coming from my non-research opinion, because it is I couldn't believe how complicated doing a research study was. Okay, so what I want to do is, because in the lab environment, when we go back there and do labs, just like yesterday with the E-STEM, it was more of a fun, we're not going to really necessarily simulate an exact patient care scenario. But if you are going to do an ultrasound on a patient, always rule out contraindications, really every time. PTAs, COTAs, always think about them, and always, you know, we're all our checks and balances. Each one of us is our own checks and balances, helping each other out. So think about any contraindications, any precautions, consider precautions. Are you getting the results you wanted? You know, we don't want to mindlessly do treatments. We want to really think about what we're doing, and is it impacting the patient, and are we seeing any benefit? Prepare your treatment area, make sure you have the equipment you need, make sure, you know, it's a safe setup. Prepare the patient, let them know what you're going to do. You know, consent for treatment is something that we really should be getting consent for everything we're doing and explaining on a level they can understand. It's not always possible, especially if they have cognitive impairment, but technically you want to prepare them and let them know what to expect. You don't feel much with ultrasound, you know, so if you have that skeptical person who is on the lookout for fraud, you know, for Medicare purposes or something like that, you do really have to communicate with the person, because they may not tell you to your face that they think you didn't know what you're doing, or they think you are doing something unethical. They may or may not say it to your face. They may be thinking it as they go out the door. And that could be any treatment, anything you're doing. So you really want to communicate with your patients why you're doing something, what they should feel, what they shouldn't feel, because you could also have that patient who could be experiencing discomfort and they don't tell you until it becomes literally unbearable. I've been guilty of that when I was getting a massage one time, just thinking that doesn't really feel good, but you know, you don't want to say anything because it's a nice person. But I don't want that. I don't want to be doing something with a patient that they're withholding information about discomfort. That's not okay. I want to know. So I would tell the patient, you know, I need to know what you're feeling. Describe what you're feeling as we're doing the ultrasound treatment. I wouldn't expect you to really feel much of anything except the head moving over your skin. So explain what they're likely to feel and how to communicate with you. Make sure they can communicate adequately to make the treatment a safe one. Position for comfort and effectiveness. I'm going to position them differently if I want to relax a muscle spasm and I need them to be very relaxed, versus if I'm trying to increase range of motion and I want them to be in a stretched position. So there's going to be a variation depending on the outcome I'm trying to accomplish. Determine your parameters. You know, it matters that you look confident. I've had to go in and do things before where I was like, I hope I can pull this off, because I've never used this thing before, you know. Have you ever have to use some device or transfer device or something that literally took 2 minutes to figure out how to use it? Well, clearly don't do it if you don't feel confident. But, you know, if I haven't used a machine in a while and I turn it on and it's going to take me a minute to figure out how to maneuver through the parameters, I'm going to try and do that where they can't see me, because I don't want them to see me looking not confident. You know what I mean? So I'm going to try to protect them. I've had so many therapists call me in and say, hey, can you help me set this machine up? And I can't figure out how to get it onto whatever we just did. It's usually E-stem, because they're the more complicated to set up. But I don't like that. I'm like, let's not have this discussion in front of the patient, because especially if it takes me a minute, well, hold on, let me remember. Okay, yeah, we have to go to this other field. It just decreases their confidence and their you know, safety and their caregivers. So try to do those things outside of their, outside of them. Get to know your equipment first. I know our lives are busy. I know a lot of us are under these kind of ridiculous productivity requirements, and I'm sorry for that, but we still have to do things right and safely. If there is a machine that can be preset, and it literally can say room 222, and you set it up the way you want it for room 222, it's going to make you be able to be faster in front of the patient, which, again, defies billing standards, but it still would make you look better and feel more confident, and then you can pay attention to what you're doing rather than trying to remember how to set up the machine. Apply your gel or lotion and spread it with a transducer. So again, I would put it on the head itself that's clean, and then spread it with a transducer first to prevent as much contamination. Yes?
No. I was thinking about cleaning it. My facility uses, you know, the guy uses bleach wipes or the other wipes. Is it a good idea to wipe it down before you use it, let it dry? Or?
You definitely want to have a cleaning method. And in a perfect world, you would sanitize it. It would be cleaned and it would be covered, and it would be labeled as sanitized. And when you approached it, you would know that it's ready to go. Do any of us work in a perfect world? No. We probably clean things more than they need to be, because we often find ourselves cleaning a surface of a mat or whatever. We're ruining our mats because we're cleaning them so effectively that we're ruining the surface. They're not, you know, our sliding board transfers have become more and more difficult because we have cleaned the surface off of them. They're rough now. But I would, ideally, if you're not sure if it's clean, yes, absolutely, I would clean it. You know, and depending where you're treating, I am much more concerned about my vulnerable patient, that I'm going to put something on them or expose them, than I am worried about, somebody's shoulder who has intact skin, But yeah, absolutely, I would make sure it's clean. And also, whether a sanitizing wipe is enough is a question that I would have. Like, this particular head, wiping it with just a wipe is not enough. Now, that's what I'm using back here, more to protect you guys from the person next to you's cold that they're brewing or the flu that they're coming out down with. And really, where I'm worried about that is the face of the machine and the handle, because each other is gonna touch it and rub your nose. That's more likely how you're gonna transmit illness to each other. So for me, it would be more globally, wiping down the whole machine, the knobs that you've touched, the handle, the wire, anything that, you potentially could clean. And I wouldn't think, so this particular one, I would more dunk it in something, or make sure it's very, very wet and gets up in the cracks and crevices to make sure it's clean, especially as an ongoing. Because even if you didn't do a really good job once, you may be okay. But if you're day after day not quite cleaning a piece of your equipment well, it could catch up with you, and then you could have a problem. Yes?
For the actual pen or the crystal part, is there a cleaner that's better than another, or like, something that would damage it?
I mean, any product that says kills 99.9% of organisms on contact, most of your facilities have someone that has gone to great measures to pick a sanitizing agent that you use based on your needs in your building. Depending on what they have, like C. diff. If you have a facility that C. diff is nearly impossible to kill, I mean, it's really, really a hardy organism, but generally they're going to use something that's pure, that's got pure bleach in it. So what you're using is typically going to be the demands of your facility. And again, I still find that the way you clean it and using good hand hygiene is going to be the number one thing you can do, is specific to your device. You can always ask the manufacturer just to make sure, because they may tell you you can use certain solutions on the head, but not to use it on the touch screen or the wire itself, because of a bleach could be drying and damage it over time. Or they may tell you you can use bleach, but you need to rinse it off afterwards. I would just recommend, depending on your device. But a lot of them, there are cracks and crevices that you should be concerned about. So if I'm taking it in a room or using it on somebody who's very vulnerable, I may put a bag over the device. They also make a little screen protector that basically you put over top of any kind of mechanical device that you're using, and you touch the buttons or turn through the bag, and that way you're not actually touching it and exposing it. So there's all different methods depending on your setting and your level of infection control that you're having to use. I don't know if that answered the question, did it? Or did I dance around it? Okay, good, okay. Okay, so from a setup perspective, increase the intensity and move the sound head. So I've been taught and I've read to move your sound head about 3 to 4 centimeters per second. That's what the scientists have said. And that is to not move so fast that you decrease the ultrasound's ability to penetrate, and not move so slow that it allows hot spots to build up. So 3 to 4 centimeters per second. If you want to visualize that, if you're making a circle, that would, a quarter is 7 centimeters around. So if you move around the circumference of a quarter in 2 seconds, you'd be going exactly 3.5 centimeters per second, which would make the researchers happy. Exactly in the middle of the speed that they recommend. If you're going in a line, imagine 3 to 4 centimeters and move it in 1 second increments. So if you're picturing, the speed, 1,000, 2. Most of our rooms in our facilities, which we don't have any second hands in here, we have second-hand clocks in every room that we have, because I'm constantly wanting a second hand in order to take pulses and things like that. So I would be looking at the clock and gauging my timing, especially if I'm talking. I don't know about you guys, if you watch other people do ultrasound during the lab this afternoon, you'll notice that if you become distracted, you may either stop and stall, or you may go too fast. Mine usually goes with the speed of my voice, which is too fast. So watch yourself. The treatments are very short. I would try to focus on what you're doing, you know what I mean? You definitely, a lot of people, I have a hard time not talking when I'm at any time in my life, but if I'm talking to the patient while I'm doing the treatment, I'm gonna make sure that I'm being careful to pay attention to what I'm doing, this short treatment, to make sure it's effective. So if I'm gonna talk to them, hopefully I'm talking about what we're doing and in order to try and make it as effective as possible. So about 3 to 4 centimeters per second. Too fast is gonna decrease the penetration, and too slow is gonna increase the risk of hot spots and not being very uniform. If the patient complains of discomfort, pain, meaning thermally, it's getting too hot, move off the area. You know, you can either stop the treatment, or if you want to keep the treatment going and you don't feel like it's time to stop, you decrease the intensity, but immediately move off the area because it's too hot. Cool it off. So if you're doing a small location, a small treatment area, immediately go bigger. And if they have vascular tissue, it doesn't take long for it to cool off. So allow it to cool down. It could be, it's not a good thing. I don't want to cause discomfort. When I do ultrasound, it shouldn't hurt. So that's not a good thing. But it could be that you have approached that upper level of thermal and that you are aggressively heating. I don't want to keep, it shouldn't be painful. So you need to decrease the intensity or increase the treatment area. One of the things I say a lot is, and I think one of the things that makes ultrasound not repeatable, and it's something we were talking about, is to try and make controlled studies that are truly controlled. If they don't use, for example, a template and a robotic arm to deliver that ultrasound, how do I know that you did the same thing that I did? How do we know that our treatment was delivered the same? Because the number one thing, you know, we get all caught up with the intensity and the duty cycle and the frequency, but the number one thing, in my opinion, that affects the amount of heat being produced is your technique. So if I'm treating lateral epicondylosis, for example, if I'm doing a treatment and I'm going about twice the size of my sound head at a speed that's, you know, at this rate of speed, and then someone else does what they consider the same treatment, all the same setup on the machine, but they're going bigger and faster, they are not comparable. The outcome I would have gotten is not comparable to the outcome you would have gotten. How do you control for that? It's really tough. So, you know, one of the things I challenge people to do is do it on yourself. Do ultrasound on yourself. Different ways. So in a lab type environment, I'll tell people, okay, if you're trying to do a thermal treatment, this isn't for a therapeutic outcome. This is for an education and just to learn for yourself. Do ultrasound. Get a setting. You could do it on yourself or you could do it on a partner, and set the machine up and get it to a point where you're starting to feel a little tiny bit of discomfort. So go kind of slow and kind of small. No bigger than twice the size of your sound head. You have to move. But just get it to a level where it's just beginning to get uncomfortable, and then go a little bigger. And notice how it won't be. Then go a little smaller again. Starts to get uncomfortable, go bigger, goes away. I mean, don't do it a bunch of times because we don't want to end up looking like cooked chicken, isn't that what they said? But regardless, don't do it for a long time, but it's a good learning experience to know that, boy, we can go, just a slight change in speed and space can tip the scales from a little bit of heat that's maybe therapeutic to harmful levels of heat that hurts. So a big problem that we have is how do we take into account all the differences in each of our techniques. And when you watch each other, when you do ultrasound, you'll see that everybody's a little bit different. So again, it's a problem I can't really solve, but we can just talk about it and think about it. Okay, so design a treatment program. Well, is it indicated? We talked about, I think some clinics overutilize it. They do way too much with not a lot of thought as to why they're doing it. Some clinics, people are pressured into doing it. They're pressured into always including at least one modality in the treatment because of reimbursement, which is unfortunate. And then there's people who never use it. They just don't use it. Maybe they haven't used it in so long, or they just haven't found a need. And any of these situations would make you want to think about every time you're going to use it, why are you using it, is it useful? Is it appropriate? So is ultrasound indicated? Are there specific tissue problems and a goal that you want to identify and address? Is it an appropriate target area? Is it too deep? Is it too big? You know, is it something that you realistically could target, or the target is unachievable, you know, underneath the patella, or, you know what I mean, it's somewhere I can't get to. Are they free of contraindications? So is the site too close to a growing epiphyseal growth plate on a young person? Or is it, you know, what are the contraindications? Is there a sensory impairment that you can't do it? Then my question is always, do I want to stimulate healing and I don't want heat? So basically I want to do more of a non-thermal type treatment where I want to try to stimulate some healing, but so sprains, strains, open areas, open wounds, bruises. Interesting, and you can do this one, because I know we talked about this. Years ago, I had, we put in a deck in our backyard. And I remember from what we were doing, I had developed bruises on both of my forearms. And they were similar in size. I got them at the same time on both arms. And I was really skeptical. This was before I even was teaching, or maybe I was teaching, but not like this. It was a long time ago. But I remember being skeptical about non-thermal ultrasound. And so I thought, oh, I could do a little study. So I did non-thermal ultrasound on my left forearm. And lo and behold, I should have written up a case study, but you know, this is a very, very minor study when it comes to studies, no control. But I ultrasounded my left arm, and those bruises, you know, did that change into yellow and went away, and that arm was all healed up and cleared before this one was. So I thought it was really interesting, you know, that I had a resolution. Now, I didn't have a medical problem, anything like that. I am right-handed. There's potential that I, you know, use this arm more and caused it to take longer, or we could argue that it should have gotten better faster because of all the muscle activity, but regardless, it was a really kind of cool opportunity to try something. So again, that's the kind of scenario that I technically talk to people about and I might utilize ultrasound for. Heat and stretch. This would be more, and I say chronic on there, but technically anything that you want to heat and make longer. If it is tissue that you're going to try to heat it up, increasing that sort of plasticity, pliability of it, and stretch it while it's heated. Or if it's something that you want to heat up for pain relief, something you want to heat up for more aggressive blood flow, like a muscle spasm, all of those things make sense. So contracted tissue, tight tissue, muscle spasms, just pain in general. It's a fun thing to do, to just say, well, I've got some I can palpate and I can feel some discomfort here, some pain in this area. Have your partner ultrasound it, make note of how it feels to palpation, and then have your partner ultrasound it, and then feel it again. And just see, same as with point stimulation yesterday. The same idea is try it for yourself and see how it works. Okay, so choosing parameters from a non-thermal perspective. You know, the problem here is you have to go by research, which we've already established is, you know, there's a lot of concern about the level of research that we have. But the majority of studies that were done that had outcomes that were positive used 3 megahertz. And the reality is those studies were done on superficial targets. I mean, medial lateral epicondylitis and open wounds are the most common thing that I've ever seen. And they're not tons of studies, but the ones that are there are usually done on these superficial targets. And so I stick with 1 megahertz. As long as it's appropriate and your target tissue is within that 2 centimeter range, use the 3 megahertz so you can mimic those studies. If your target tissue is deeper, you have to use 1 megahertz. Does that make it still comparable? Not exactly, but you're not going to get there. The energy will not achieve its target if you don't choose the 1 megahertz. Frequency, 0.5 watts per centimeter squared is the #1 most common intensity that has been used, so that's the one I recommend. I would go up if it's a deeper target. Now this is my theory and it's not proven, but my theory is, well, 3 megahertz is, if you switch to 1, you automatically are getting 1/3 of the energy. And you think about it, if the reason they think you're getting it is the vibration, you're getting 1/3 less of that. So my thought would be, increase your intensity simply enough to make sure it achieves its target. You want to make sure it gets there. And also treat a little bit longer treatment to make sure the energy is, you know, you've delivered as comparable amount. At least that's the attempt. Yes, ma'am.
So I have a question. So these portable units
Mm-hmm.
are calibrated to a certain, intensity. So how do you change? You can't change anything. You have to use it at that intensity.
Do you know what intensity yours has?
I'm not sure.
Yeah. I mean, that would be my question is, can you even compare? You know what I mean?
Right, I
I
mean,
mean-
so you're actually doing a treatment, and, I mean, maybe 0.5 is better, but your, you know,
Your machine just
right, your
doesn't
portable
do it.
one does 1.0, you know.
I
Lots
mean,
of
1.0 would be higher.
Right.
At least you know you've got enough. You-
Right, right,
I don't know, arguably, you'd rather have enough, because if it's very, very low level, the question would be, can it even penetrate the
right,
skin?
is it
Would
beneficial, is it
yeah,
even
would
doing
it-
anything?
Would it do anything? Yeah, I mean, that's a challenge. I don't know what, because I've looked at some of the
I
portable
think the
devices,
portable
and
ones are
many
all
of them are so
calibrated.
low.
Right, and I think they're all calibrated at the same calibration, and they're not able to be changed from what, you know, except the one that you showed me, that yours has the panel on it.
Yeah, so I have this portable device. This is a Mettler product, and my battery's charging over there, but basically this is the portable. It's, you know, the battery would go in here, and when I first saw it in the ad, it just showed this part, you know, so I envisioned it being just this. But when I've talked to the company, they've said that without enough power, you can't do enough energy to replicate what we as physical therapists do. So you can't get a comparable amount of energy as what you get with your clinical models. And so that was as portable as you could get in order for them to get that amount of energy. You know, whether any of these other devices, because I have seen them advertised for like $100. This one is, I don't know the exact price, but it's over 1,000. I mean, it's far more than the ones that you can see in these magazines. And so this one has much more power, and it's designed to mimic what you can do, the same amount of energies you can get with a clinical model. So you need a bolus of energy. So when we do our lab, you guys can play around with this one and use it. It's, again, this is as portable as I know that you can get for sure. I'm not aware of any more portable devices that can create that kind of power. But I'm not saying they don't exist. So duty cycle, 20%. We were talking about 50%. That might be fine too, I don't know, but there are just not as many studies. Most of the studies that I've seen, again, on skin and superficial areas, utilize 20% duty cycle. Now treatment time, this is something that was interesting, is 2 minutes per size of the sound head is what is most found to be effective. And the way I look at it is, when we talk about heat, we'll have a different type of recommendation. So what was recommended is 2 minutes per area the size of your sound head. So let's say my target was, you know, let's say from here to here, and I was gonna target this area. I would do 2 minutes, approximately twice the size of my sound head, the same rate, at 3 to 4 centimeters per second, and then I would go to an overlapping segment, do 2 minutes there. And then an overlapping segment for 2 minutes there. You know, if this was more of a round area, I would do the 2 minutes in one little quadrant that's more than, you know, no more than twice the size of my sound head. I would move to the 2 minutes in the next quadrant, and then 2 minutes here. So my treatment may end up taking, you know, 8 to 12 minutes or something, but I would do 2 solid minutes in that area. Now, the way I came up with the plan is the idea that that is different than going around and around and around. The idea that you want to create some sort of a physiological cascade of events, that sounds fancy, right? So you want to stimulate the cells enough that you create some sort of event that it transmits. And I came up with this just based on what I've read, is the idea that maybe a lot of treatments that are being delivered are just not being done enough, that there's just not enough energy that it caused anything to happen. So that's a method I use, is 2 minutes over an area before I move on to the next area.
So I have a question, is
Sure.
it better to go back and forth or circular? I mean, or it doesn't matter as long as you're covering that?
To me, I would move in a way that physiologically makes sense. So
Okay.
let's say your target is a linear tendon. You know what I mean? It's linear. My plan would be to go more
Back and
linear.
forth.
It just makes more sense that if you think about how the ultrasound energy comes out and the uniformity of it, I would feel like going in a linear way would be more likely going to get as much energy deposited as possible, versus if it's maybe a muscle spasm that's, you know, you've got the center of a muscle,
Right, right.
which I don't know if I would do a non-thermal there anyway, but you know what I mean? If the shape of the area, let's say a wound, if it's a wound target, a circle may make more sense.
Or like a knee,
What about like
mean-
a shoulder or something that's,
right, more
Yeah.
rounded.
it does
See,
more
and that's
rounded.
where I would take you the next level. Instead of it being a shoulder or a knee, what exactly is your target? You know what I mean? So for me, it would need to be the collateral ligament of the knee. You're gonna have to give me one, a acromioclavicular ligament or something, you know what I mean? But it would have to be
How about a strain? What about a muscle strain?
a muscle strain, yeah. I mean, again, I would, depending on the shape of the muscle, because we have long skinny muscles, and we have short fan-shaped muscles, you know what I mean? So my trajectory would follow the shape of
The
the
muscle.
tissue.
That is,
Say rotator cuff.
Yeah, and those are linear, but they're small, so I would still be thinking a little bit more on a linear or oval kind of trajectory.
Would you apply that if, like, patients have visible varicose veins, but they're never diagnosed that it's, they needed to do something about it?
So your target is under the varicose veins, or that is your target?
Under.
I mean, I wouldn't have a problem with doing ultrasound. If I had a really firm, bulging varicose vein, I would go adjacent to it if I could, not go right over it. That's a good question. I've never had that asked before, is that?
Because sometimes you go around on the leg and then you see those varicosities, but they say, oh, I've had it for years and it doesn't bother
I mean, a
me."
varicose vein off the top of my head doesn't jump out at me as a contraindication. But
that's what
if
people
it's
have.
bulging and red and
Jumping
inflamed,
out.
I would not.
Right.
I would not. Like if you think phlebitis, I would not be doing ultrasound. You know what I mean? But if you have a target on somebody who has a calf strain or, something like that, and you want to do ultrasound, if I could avoid directly over a bulging varicose vein, I probably would. Not necessarily because I think I'm going to harm it, just because I don't know. You know what I mean? More because lack of knowledge than anything.
So now, treatment area can be like 2 to 3 times the head. And you said should do like about 2 minutes. So if you're doing the three times the head, is it still 2 minutes in that area? Or?
Okay, so let me clarify that. When I say no more than 3 times the size of your sound head, that's kind of for thermal. That's much more for thermal based on the fact that if I'm and I'm going to move on to that next, but if I'm trying to heat an area, if I spread it out too far, it's not realistic to think I'm going to heat an area bigger than 3 times of my sound head because it's just going to be dissipated out. If I'm going to do more of a non-thermal method, if I want to stimulate healing and I don't want heat, I would be looking at about 2 minutes at a time per area the size of my sound head. So again, that whole idea of small trajectory for 2 minutes, and then I would move on to the next. Now you could treat a very large area, but it's going to take you, you know what I mean? It's going to take you 2 minutes for every space that size. So it's going to take you longer. So it's not that you couldn't do it. It would just take you a significant period of time, and I question whether I really need to do that or not.
Yeah.
But from a thermal perspective, which is what we're going to move to, should we move to it now? Are you ready? Do you feel like we're good with this for now? Because when we do the case studies, we'll end up coming back on this again. Okay, so from a thermal perspective, it's a little bit complicated because you have to think about the frequency, the target tissue, the depth. Your technique is going to, again, play into this very, very significantly. So what I've tried to give you here is a chart. Now, I made this chart. This is not out of any textbook or anything. This is something I came up with for this class, so for us to go over together, is the idea that if I'm trying to treat muscle, if I'm trying to heat it up, a section of muscle, every one of these is intended to be treating an area no bigger than 2 to 3 times the size of my sound head with a technique that would be similar. No more than 3 to 4 centimeters, about 3 to 4 centimeters per second of movement, no more than 3 times the size of my sound head. This would be, in my mind, this is the range of what would work, but the machines are different. All our machines are different, so again, you have to take into account that. So if it's a muscle and you're using 3 megahertz, I'm assuming it's a more superficial muscle, which is likely going to be smaller too. So the theory there is we're talking about maybe an intrinsic muscle in the hand or the forearm of a small person. Because even the forearm of a lot of people, those muscles are bigger, are going to be more than 2 centimeters deep, so I'd probably be using 1 megahertz. So if it's 3 megahertz, my thought is that if you're gonna try to create heat, 0.5, these would all be continuous, no pulse, no duty cycle. 0.5 would be the lowest I think you probably are gonna likely get any heat produced. And 1.5 would be very high, meaning if you do 1.5 and you're treating twice the size of your sound head, they're going to encounter some discomfort at some point, and you're gonna have to go bigger or turn it down. So these are meant to be, in my mind, sort of the lower and higher numbers. Now, add into that your technique, and it's gonna make a big difference. Just to go through this chart real quick and then return to a few thoughts. 1 megahertz, my assumption is the muscle is bigger, deeper, and so I kind of moved the range up to 1 being the lowest number I feel like would be clinically appropriate, up to 2, which is what most machines max out at. Most machines don't go beyond 2 watts per centimeter squared. And I put 5 to 10 minutes there. Not that you couldn't go longer, but your arm is going to be tired. It's a modality that is relatively boring to listen. I mean, 5 to 10 minutes is most likely going to reach your and your patient's saturation point for the treatment itself. Now, connective tissue. This is things, tendons, ligaments, joint capsules, which have lower vascularity. They generally are more superficial. You have superficial at the wrist, and then you have this, you have this muscle tissue, and you have much more depth and vascular tissue in between, and then you get to the elbow and you have superficial again. And then you have this muscle, and then you have areas of superficial. So the idea is the connective tissue, 3 megahertz would be if it's achievable, if it's within the 2 centimeters. I put down 0.5 to 1, and I put shorter treatments. I mean, the reality is you could heat it up faster. And then 1 megahertz is deeper. So this could be maybe a hip tendon or ligament, shoulder underneath the deltoid, things like that. So it's something that we have to pass through, penetrate to get to it. But they likely are, they insert on a bone. I mean, these inherently insert on a bone. So the theory there is you've got that reflection off of bone, and you can capitalize on that energy. So again, I put 0.5 to 1.5. So these are ranges I put in there to say that at the upper range, if you're using the 2 to 3 times the size of your sound head, they're probably going to experience and encounter some discomfort, and you're going to have to make some adjustments. If you're at the lower end of the range, it's more conservative. So if I have somebody where, first of all, I don't want anyone to experience discomfort, but if this is someone I want to do the treatment, I think it'll be effective, I'm a little bit concerned about their ability to respond to me, or that they're going to tell. If I want to be conservative, I'll go with something towards the lower end. And I'm going to treat conservatively, and I'm going to realize my outcomes are not going to be as likely or as remarkable. Not that any outcome is remarkable, you know what I mean? I would just err to the side of caution to be, in those cases. Versus if I have someone like in the lab, you guys, you're good communicators, you know what to expect. I'm going to do an ultrasound, and I'm going to say, let me know when it starts to get uncomfortable, and we're going to back it up. So if my purpose is to get it robustly heated, and I want it to be robustly heated, then I feel confident that I'm not gonna overheat it, they're gonna let me know they have good sensation, then you have the ability to be a little bit more aggressive, for lack of a better word. Athletes come to mind, or something like that.
Well, I was thinking also between like a frail, like an elderly person that has thin skin, and then you have this bodybuilder that has really, big muscle mass and thicker skin, and
So their body type could help dictate, and also the nature of what you're doing and the need to be more conservative. But also I've had little old ladies that were a lot less intimidated than somebody who looked really tough. So I think a lot of it is also, it's the nature of how they can communicate with you and what you're trying to accomplish too, it comes to mind as well. Okay, now back to the idea that with heat and the way you apply it is, again, the amount of heat you're producing is going to be extremely variable, and also where your target tissue is. I can use a good example of a site. For example, we were talking yesterday about the upper tract, the supraspinatus area. So you have a very superficial area with your scapular, the spine of the scapula. And then you have a relatively deep fossa with a lot of muscle tissue in it. You can't move over both those areas and expect to make both spots happy. You know, so if I'm treating an area, I want to try to get my target to be as light depth and tissue as possible. Because if I'm just moving around up here, it's either going to be too intense for the bony area or not intense enough for the muscular area. So that's where, when we talk about the shape, you know, do you go linear, do you go round? I'm gonna do it over the shape that makes sense for the treatment area. So from a thermal perspective, if my target is extremely variable, my outcome is gonna be risky and not predictable. You know, so I would target by moving in a way that mimics, if it's this muscle, I'm gonna do maybe a fan shaped or a teardrop shape, something that's gonna mimic the area that's depth. Same within the arm, you know, if you're moving up and down past the elbow, might be way too big of a site, plus you're going superficial deep, you know, and it's impossible to expect your outcome to be half good, the same here as it would be here. It just can't happen. So I do think your target has to make sense. Okay, so does this chart make sense? All right. What might hit or miss? I hate documentation. Don't we all?
Yeah.
There's something we could do away with. It would be, why do we have to write about it? I mean, the reality is it's getting more of a burden, and do you agree? The burden is getting worse.
Yeah. The keywords you have to always include, and
It's just overwhelming. But you know, from a documentation standpoint, if you think about what it's intended for, I mean, to me, the most important thing is that if I get sued, it's going to protect me in litigation. If I get subjected to reimbursement, you know, if they're looking at it to get paid, are we going to get paid? Is it going to, if I come in and treat your patient tomorrow, am I going to be able to figure out what to do next? You know what I mean? Is that going to relay in some
I
way?
hate that part where you have to make it sound professional or you're not gonna get reimbursed.
Well,
You know?
yeah, I mean, we all hate it. None of us like that.
Paint
feels
that
like-
picture.
I get the part about, you know, documenting so there's a record of what you did in case, you know.
Yeah.
But
I know, it's no fun, none of us like it, but the reality is we have to. And, you know, try to make it as efficient as possible. There's so many documentation systems out there, I don't like any of them. I mean, does anybody have one that they love? They're all just, once you get past the learning curve, it's like, you know, I can do it, we can do it, but I don't know that any of them are wonderful or great. But if you can use a method that's putting all those things that you need to put in a way that can carry over. I know old timey, we used to have a little cookbook thing, we had a little recipe box and we would put what we were doing and then we'd yellow out when we didn't do it anymore. It's a little harder to see that in a documentation system in a computer is, what have we already done? Did we already try this and this, and can I try that? You know, because I don't want to repeat something that's already been done. I don't have the magic ticket to how to do that so much as we communicate a lot and we try to work as a team and keep the same therapists on as much as possible, assuming that we're getting good results. Because if you have a different therapist treating someone every day, I don't really know how you can expect to get as much progress as someone who is able to say, well, we did this yesterday and we didn't improve, so let's do this tomorrow. So again, I can't really fix that. So we're going to do some case studies here in a little while, and we'll go over, if you have questions on how to document that, let me know.
I haven't seen anything that puts a limit on how many times you should use ultrasound. It used to be said that you did 10 sessions, and if you
Right,
were
right. What's the number? What's the number where I
Yeah.
shouldn't, from a
where it's
clinical
not
perspective,
beneficial
isn't-
anymore,
yeah.
or it's
it's
not
not
doing
what
what you
insurance
want.
pay for.
Right. Insurance-wise, I think sometimes they have those sort of computer edits that will pop out as excessive, you know, for this diagnosis, if they did this many, it's likely excessive. But from a clinical perspective, it goes back to when I talked about indications at the beginning and contraindications and precautions when I said outcome is not as expected. So unfortunately, reimbursement often dictates, and I hate that, we all hate that. None of us want anyone else to dictate what we want to do other than us. But your clinical judgment is what would come to play for me. So we go back to the idea that we have a person who does not have a neurological condition. This is a sports injury this is a relatively healthy individual without any neuromuscular problems who has a musculoskeletal injury and you're treating them. They should be getting better at a fairly rapid rate. I would expect them to be recovering at a predictable amount of time. And so I can't see the value of doing ultrasound over and over again. But then someone who has Parkinson's or hemiplegia, or, they have high tone, is there anything out there that says I can't keep doing this? Why couldn't I? If I'm maintaining their range of motion, or if I'm coming in and seeing them from time to time, we use the same modality to kind of achieve what we achieved once before. Who's to say there's anything wrong with that? Now, I don't know whether you can get paid for it, but if you found something to be effective and then they regress again, could you not do it again? It's all a clinical judgment. It's whether it's of value still. It's a good point, and I'm not going to be able to answer it so much as it's a case-by-case basis versus known negative outcome. Drugs for sure. You're only supposed to put this much drug in a person this much time, but from an ultrasound perspective, I'm not aware of any point where you've gone too far and you could cause harm. Okay, so you guys have your case studies? Yeah. I'm trying to remember what I have on there and what you guys are going to have, what kind of stuff this debate we're going to have. Okay. 30. Okay, so I'm looking to see if I do have epicondylitis. We'll see, this should be fun. Okay, so here I've given someone a chronic cervical strain, pain, so their complaints are pain and palpation reveals a trigger current in the right trapezius. Does that sound familiar to the super here yesterday? What are you gonna do?
I'm gonna get to Easton out.
He's gonna use his Easton.
Massage.
We already used that yesterday, and I never even asked this morning, how did everybody feel? Did anybody feel any benefit yesterday? Anybody feel? I know you had said your arm felt better. Did
Yes.
it feel? You did too, but it didn't feel better this morning.
No,
So
it didn't last.
What about you?
Mine didn't last
Yours
either.
didn't last
And I
either.
don't know whether it was the Advil I took yesterday at lunchtime, or
So
whether
we
it was the
have
ultrasound.
not a well-controlled study that we did there.
However, I was able to hold a beer in this hand last
Oh,
night,
that's
so
nice.
I figure that's progress.
There you go. So that's a good outcome. My goal is
I can medicate now.
patient needs to be able to hold his beer after treatment today. But nobody else had any kind of negative
In order to bring
or
it to his
positive.
mouth.
Yes.
I did feel the euphoria for the rest of the.
You did?
Yeah.
Okay, good.
Mine only lasted
did?
like a few minutes. No, when I had the euphoria, it only lasted for a few minutes.
So you did
but
feel
it's
sort of
still-
a mood change. in
Oh,
some way,
yes.
Yeah. I mean, that's not what we're going for, and I'm probably not going to document that. But hey, that's a little sprinkle on the icing. If you got a good outcome, and then they really were happy and felt good, and they really liked you afterwards, that's always rewarding.
The thing I discovered though was like I put that machine on 3 times on that setting. I only got it to first setting, so even on the same patient, you can't always get the same thing. That
I agree.
didn't get
Try
that
to
good feeling.
repeatable. I mean, it's like our controlled studies that we use. The Berg and the functional gait assessment. All those tests. Inter-rater reliability, repeatability. Can you do 2 treatments can you do a treatment and is it comparable to the one you just did? From one day to the next. I mean, it's tough.
Yeah.
Do we need to? Maybe not. We can still get good outcomes. I think
Oh yeah.
overall our outcomes are great as an industry. At least I see it as that way. But again, the repeatability, the ability to quantify and make it repeatable is a challenge. Okay, so this one has, what are we gonna do? Could we do ultrasound? Do you think it's indicated? Sure. How would you use it?
1 megahertz.
Okay, so would you go continuous
I would
or
continuous.
pulse? Do you go continuous? You're going for heat? You want heat?
Absolutely heat, yes.
I agree. So you're gonna go for continuous, 1 megahertz, and
1 watt per centimeter squared.
1 watt per centimeter squared. I like it.
Maybe 5 to 7 minutes.
5 to 7 minutes. I like it. Could you go higher than 1 watt per centimeter squared?
Depending on the person.
Exactly, it depends on the person. You know, even in this room, we could look around and say, I might go, you know,
Maybe
1 watt per
1.2.
centimeter square, 1.5, on some other people. It could be the size of the area, the depth of the area, their ability to communicate, the longevity of how long it's been there, your technique, because you're gonna find if you're one of those people that tends to move a little bit of a bigger area, and I tend to be one of those people that moves on a smaller area, that I could be using lower intensities and getting the same outcomes as you're getting with higher intensities, simply because even though you look at the number and you think, what are we doing differently? It has nothing to do with the number so much as to how big of an area we're trying to treat. So your own technique could also make what appears to be a really high intensity not quite as high. Okay, so position. I mean, to me, I'm thinking comfort, maybe stretch, you know, to try to get blood flow in the area, and then you could get creative depending on, you could be doing some movement, have them actively contract once in a while, or whatever they're lacking, if they have a postural problem, if they have a range of motion problem, if we don't address those same things, because anytime I say chronic, this person has a chronic problem. Why is it chronic? And could me doing a little treatment make it better? So some of you guys yesterday are talking about the things that you treated yourself with and you felt good afterwards, but it came back. So we didn't eliminate the cause of it, or maybe it was an insufficient amount of time to get a really good carryover effect. But the reality is something is causing our patient's chronic problem. Have we worked on eliminating that? So I don't want to underestimate a modality from being a piece of the puzzle, but I also don't want to expect to solve a problem that's not, it's not realistic to solve it with one treatment or one modality. So you've got to think about why do they have a chronic problem and what can we do to eliminate this returning. I know we were talking yesterday about what bad business people we are. Instead of thinking about how can we keep these patients coming back and we want to get them better, and I say it all the time, I want to get you better so I never see you again. I love you, but I never want to see you again, and that's a sign that I was a really good therapist. You know what I mean? Okay. Now this person has an acute knee sprain. So they have pain, limited range of motion, and limited function. So let's say this, okay, so medial collateral ligament. This is someone who injured their knee. Could be sports, could be a shuffleboard injury, something. They injured their medial collateral ligament. So this is one that, what do you think? Is ultrasound indicated?
Yeah, I think so. I mean,
Okay.
range of motion.
All right, so you think so? And what are we gonna do? Are we gonna use continuous or pulsed?
Pulsed.
Okay, so pulse. We're thinking healing but not heating. I agree. Okay. Now, the location of it, what would you think for your
I think it depends on the size of the person.
It does depend on the size of the person, so whether they're really teeny tiny or fairly large. So teeny tiny person, the ligament can be fairly superficial, so 3 megahertz could work. And if they are large and there's any debate there, you know, I always say, if we're questioning each other and we're saying, well, what frequency would you use? If I'm hearing crickets, meaning I'm hearing them really think about this and they're looking, trying to determine how deep it is, if there's any doubt, my thought is the more conservative approach would be to go 1 megahertz because it's gonna get there. At least I know it's gonna get there. And I can always back off, but I just wanna make sure it achieves the target and gets through the whole ligament. So if there's any doubt, but in this case, we're gonna base it on the size of the person, but 3 megahertz is very likely gonna be okay. What about duty cycle? We said 20%, sorry. And intensity.
0.5.
Yeah, so most of the research used 0.5 watts per centimeter squared. That's absolutely fine to mimic that. I wouldn't have a problem, let's say if you wanted to go up a little higher, if it was a person who was bigger, simply to say, well, the study I was using to go by, this is clearly going to be a deeper, bigger target. But is it necessary? Not necessarily. And do I have evidence why? Not really. No. It's simply going by likeliness of me getting enough energy into this target. And your technique. How would you position the person? I mean, I would just say a position of comfort. A position of comfort that exposes the ligament.
A little
flexed over a bolster, just a comfortable, slightly flexed position, makes sense to me. Certainly not a position of stretch or anything like that, it's just what about goals? This is one that, how do you document? I mean, in general, if you have somebody who presents with more of an acute injury, musculoskeletal injury, how do you document progress?
Decrease pain,
increase
increase range of
mobility.
motion.
Exactly,
Increased
function. So decrease pain, have them quantify their pain in some way, a 0 to 10.
Long banker.
Yeah, if they're reliable, I mean, how reliable is that method? But it can be a very useful tool. You could also quantify outward signs of pain with sit to stand, outward signs of pain with gait abnormality, difficulty bearing weight. So again, there's a lot of methods you can use to assess somebody's musculoskeletal impairment with their limited function, with the impaired range of motion, and pain. And those outcomes being solved. Do they need ultrasound? You're going to say no, right? You're going to say no because I'm skeptical anyway. Is it going to be of benefit?
Try it.
And again.
It wouldn't be my first choice.
Okay, so my question is going to be, I'm going to look at things like probability. And I'm going to say, okay, this is a young, healthy person who has a very high probability of getting better. They don't need it. Why would they need ultrasound? Now, on the other hand, if this was someone who treated elite athletes, and they're like, I gotta be back in the game by Friday, and I'm like, I don't know if this is really gonna help, but I see no reason why I couldn't try it, and it's not gonna harm you in any way. Well, let's do it. We're gonna do it because there's no probability of harm, and there's possibility it could be of benefit. But if it's someone, I just want their body to do its job, and their body is likely gonna heal. I don't see any reason why they're gonna have any kind of a negative outcome. I don't need it. I can look at them and make sure that they aren't causing any more harm and help them return to normal and weight bearing and all that kind of stuff as the time goes by. Now let's say this is someone who has had a history of injuries that didn't heal. They didn't get well. This is someone who is an older person, someone who's got some compromise in some way, pulmonary or physical impairments, they have Parkinson's disease, they have, this is someone who a period of sedentary behavior is going to have strong repercussions. If they spend an extra week not walking, that week of not walking is going to have big repercussions. In those cases, again, kind of like the elite athlete, I'm thinking, why not? If I can get this person walking and moving and transferring as quickly as possible, I'm going to hopefully prevent them from having a permanent decline in function, or a decline in function that could amount to a bigger problem than if they were just someone who, yeah, they're getting around, they're okay, they're going to go back to their normal, and there's not going to be a big loss. But, the longer someone who sits around is sitting around, and they are going to be impaired by it, and they're going to have, every day that goes by, there's a big repercussion, that's the person I would say, absolutely, I'm going to try it, because I want that possibility of getting them walking and healed as quickly as possible. So that's the reason I would kind of justify it in that situation. Make sense? Yep. Okay. Next one, shoulder contracture, so frozen shoulder. This is a diagnosis. If you look frozen shoulder, the bolus of the evidence is going to say no, it doesn't work. The recent meta-analysis, and even I believe there's a Cochrane review on this specific subject. If you're not familiar with the Cochrane collaboration, they basically do the meta-analysis and they periodically update them and they look and they give you a nice one-paragraph opinion. It is the opinion of the collaboration and the authors that this modality is not effective. It has not been proven to be effective than whatever alternative they may talk about. So this is one of those that says that. So even with that in mind, I still put it on my case study simply because I feel the most effective way when I do use ultrasound, it's almost always on a shoulder. And the reason I use it is almost always because they have a limited range of motion. And is the outcome better than if I didn't use it? Well, I don't know. I can't tell you for sure, but I think it is. I think it is, and I think it's a less painful process too. I also use E-stim on a lot of them because many times there's a motor impairment going on that's adding to this. But I also do a lot of opening up the pectoral cavity, opening up the pec minor, adding, postural exercises, scapular strengthening. So it's, if I did not include the ultrasound, would it have still achieved that same outcome? Possibly. But this is where I very well might use it. So I put in here frozen shoulder, not because we're actually having a patient in front of us that has frozen shoulder, but because that's what the doctor called it. Because have you ever gotten somebody with a diagnosis of frozen shoulder and they didn't have frozen shoulder? They didn't have the, whatever you would call it, adhesive capsulitis or this progressive condition that you would really call that condition. But I get it a lot. Even where I am, I have people with absolutely not a frozen shoulder. They have postural problems, they have impingement in the front, they're getting pain, but they're being, the doctor's writing frozen shoulder, just like they have a little skin tear and they say they have a pressure ulcer that they staged, which you don't want to do either. You know what I'm saying? So I'm not insulting doctors, I'm just saying that's something I see. I do see that quite a bit. Because those doctors know a heck of a lot more about a lot of stuff than I do. But, okay, so this person, would you do ultrasound? Could you do ultrasound? You could. Okay. A lot of you would, and I can see your faces. But if you were going to, and your goal was to increase external rotation, what would your target tissue be? Well, it could be the capsule.
The capsule.
It could be tendon, ligament.
Tendon.
Exactly. You're going to have to assess the patient. So this is what I would recommend. You assess the patient, you identify what's tight. It could be that they have a forward tight pec minor, and that if you identify a pec minor tightness, could you ultrasound it and stretch it? Okay, so exact idea. So you're gonna, if you're gonna incorporate ultrasound, what are you doing it for?
Range of motion.
So range of motion, but physiologically, heat and stretch. We agree, heat and stretch. Yes, my purpose would be heat and stretch. I think you missed my part about like a muscle, pec minor's tight or something like that. Right. So let's say you have a structure that's tight and you're trying to increase it. That's what the limitation, that's what we're saying here is limited external rotation. We have limited motion. Okay, so you identify your structure and you're going to do thermal levels of ultrasound. So what frequency would you use? Depends on the structure, exactly.
So
Depends on the structure and the person.
If we're saying pec minor, at least one.
So
Definitely
if it's pec minor and
One.
they have muscle tissue because they're not completely atrophied, then yeah, I would agree that 1 watt per centimeter squared would be the likely, depending on their size. If it's a ligament.
Question on that though, I mean, even if it's a little old lady, the pec minor is under the pec major, you have to get down
You gotta
to
get
it.
through it. So as
So
long as
it'd
that
still
muscle
be
is
one-
there and it's of any size, you're still gonna need the 1 megahertz in order to
It's
achieve
still
your
needed,
depth.
yeah.
Okay, okay. What about, somebody had said capsule. What if it's the would you agree it would be the anterior joint capsule if you have, no, where would it
It's
be?
totally not.
Okay, what is it?
It is posterior capsule. The reason you have the
Posterior.
frozen shoulders, your posterior capsule has shrunk up
Okay.
towards the bad posture.
Okay,
And if you don't open up the back of the shoulder, your glenoid, your humeral head is not gonna move back
it's not gonna
into
go
it.
where it needs to go.
So it's posterior capsule restrictions with stretching in the anterior capsule, because that's where they sit typically with their bad posture. And then the other problem is the elevation of the humeral head because of the overactive upper tract impinging on the supraspinatus.
Okay, so we have you definitely have more of a handle on this particular shoulder. Okay, so, if you wanted to use ultrasound, I'm not sure, for heat and stretch, so you're not a believer in it.
It's not gonna get deep enough, and the capsule's too big a, it's not one small area of the
No,
capsule.
I agree, it's not, yeah.
It's a massive restriction of the inferior capsule and the posterior capsule going up and forward.
Okay, so that's not a target tissue you're gonna use.
No.
So you're gonna find a target, if you don't find a target tissue that is an appropriate target tissue for ultrasound, no ultrasound. If you identify a structure that is a reasonable target and would be, it'd be reasonable to heat and stretch it, we'd go with that route. So looking at pec minor, looking at a ligament or a tendon. Agreed?
Yeah, you would definitely stretch the pec
Yeah.
if you want to do, if you want to use ultrasound to stretch the pec.
Right.
But you- what you
So
have
we're
to do-
using 1 megahertz to get to that target. We're using continuous, agreed? What about intensity. So again, it's back to the size and the depth and how big this person
That
is
might
and
come
your
in.
technique as well. So 1 watt per centimeter squared, all the way up to 1.5 or 2 watts per centimeter squared. Combination of the size of the muscle, the size of the depth of the area, combined with your technique is going to make a big difference. And this is something I want to practice in the lab. It's definitely feeling the amount of heat that you get based on the size of the location, combined with these other factors, the parameters. Okay, this is going to be another fun one. So now we have acute lateral epicondylitis. So we took the same idea, so acute lateral epicondylitis. This is someone who comes to you and says, I played in a tennis tournament. I don't know, I'm just saying, they played in a tennis tournament a couple days ago, and they're just sore, and they want to be back playing pickleball by, by the weekend. So unrealistic expectations, but this is someone who comes in, and they have what they're calling an acute. What do you think of that? What do you think?
Non-thermal.
Okay, so you're thinking non-thermal for healing of tissue.
Like the
Yes.
knee, the knee.
Yeah, so back to the same idea with the other ones, you assess the patient. Because even an acute problem could be, you know, you're gonna question, you know, why did this happen? Is it truly just because you overused it that one day and you did it? Or do you have potential problems that could become chronic down
I
the
mean,
road?
something like that, I mean, they've obviously been playing tennis, so.
I don't know, that would be a question I would ask. Was this a once a, you know, every 5 years you were in some sort of a thing that you did for a fundraiser?
And
or-
also, the majority of people with tennis elbow have never played tennis.
Oh, really? Okay.
Very rare. It's usually associated with other activities that they do.
Yeah, no, I agree
Not
that
tennis.
they often give it, I didn't call it that, no. So I agree that I have it, I get it. Mine's gait belt epicondylitis, you know what I mean? So I think it's gait belt elbow because of something I do every day. I couldn't hear you. So,
Sorry.
oh.
Sorry, my watch couldn't hear
So,
me.
that's okay. Or after having a baby, what's, Dickwear veins, I think is what the problem, you're gonna be my expert here, because I'm gonna use the wrong terms. But, you know what I mean, overuse, but did it just happen after one episode because it was that long and repetitious, or is it because of the straw that broke the camel's back? Meaning I'm doing these things a lot and I'm okay, and then all of a sudden I cross some sort of threshold and it's hurting. So, I mean, clearly, I've given you limited information here, and it allows, I hope, for a good debate and a good conversation, because I find that can be really helpful. But in the end, you evaluate the patient and you find out if this truly is an acute inflammatory condition. This is someone who did do something and they are acutely injured. The idea that ultrasound might help, and I would probably go back and use the exact same argument I used up with our knee strain, is I would say, if I ask, do they need it? You know, I think we could all argue that no. Is it a necessary component to healing? No. Is it medically necessary? Probably not. That would be a stretch to argue. But could it be of benefit? Again, possibly. So my argument would be the same idea. They are pressuring you to get them better faster, and you oblige, not because you think it's going to cause any harm, or it's simply because, well, I don't think it could hurt, so let's try it. Or on the other hand, they have a low probability of healing, and your thought is they have had a history of other injuries that did not get better. They have a probability because of steroid dependency, or things that have caused them to have a slow recovery. Now, this would be harder for me to justify of a functional loss, but it's still there. I mean, this would be less than, not that they can't walk, they can't get up and walk around. That is a concern, that somebody's gonna really lose their ability to function and lose their endurance. On the other hand, this one, it could cause them to be unable to take care of themselves and safely. And yes, if there's a possibility that I could get them better faster, get them back to independent functioning, why not, if it's not gonna hurt anything? So that would be my thought process with this one. So if if I was gonna proceed with it for healing, okay, so based on this location, what frequency would you use? 3 megahertz. I mean, this is a superficial area. What about duty cycle? Would you use a duty cycle?
Yeah.
Pulse,
Yeah.
would you use, so 20% duty cycle? Intensity.
0.5.
I mean, 0.5 watts per centimeter squared, I can't argue with that. I don't have any reason to argue with that. Yes, I would do that. What do you think? Okay? All right, moving on. Oh gosh, I gave this person lateral epicondylitis. Here we go for more of this. So basically, this person has chronic, so same idea, but they absolutely come in saying, you know, this keeps happening, it keeps coming back, or I've been having this for months, and I just can't get over it. What do you think there? Would anything change about your treatment?
Use a thermal.
I mean, I would definitely,
Thermal and
yes,
also
definitely, I would go
stretch.
thermal
This is
too,
where I would do the stretch here.
the stretching, yes.
At this-
So-
at this point.
So, all things the same, would you keep it all the same? 3 megahertz?
Yes.
Yes. Would you keep the, okay, we would use continuous, agreed? Would you keep the 0.5 the same?
Might go to one.
I might.
Okay, so depending on the size of the person, you know, if it was my arm versus a man who has a very large muscle, I would definitely alter the intensity. A big thing that's gonna come into play is your technique too. And the reality is you'll see it when you start doing your lab, is my technique might vary how much intensity you're getting versus your technique as well. But yeah, I would very likely increase to 1 watt per centimeter squared versus 0.5 if the person has an amount of muscle tissue that's larger, smaller. Okay, what do you think? You feel okay about the ultrasound topic? I think I have a couple of slides and then we'll do our lab. Care of equipment. A lot of this is dictated by your
Facility.
the facility and their
equipment.
licensure. So the majority of facilities that all the ones I've ever worked in, we had to have our equipment inspected every year. But know what they need. I mean, what they're doing is, you're legally required to do, I shouldn't say legally, but based on our oversight, we're required to have them every year electrically safety checked. Not necessarily calibrated and checked for calibration, but do it as much as you think you need to. I mean, if your equipment is, you know, not treated properly, or if you drop it, or something happens and then you're not sure if it could have been damaged, get it checked. That is one thing that, because you have a license, and I say this to fellow therapists a lot, and I think it in my head too, it's a lot of responsibility. You are responsible for making judgment calls and making safety calls. So, you know, I tell people at work, what would be very frustrating is for someone to say, when you realize something's not working properly, and then someone says, oh yeah, I thought there was something wrong with that. I'm like, and you didn't alert anybody or take it out of circulation? Because, yeah, that's my thing, is it's up to us to not overlook something like that. If something seems wrong, right away, either you take care of it or alert somebody who's the appropriate person to say, you know, I'm not sure this is working right. Or, you know, the last 2 times I did ultrasound, it just, nothing's happening. I don't feel like the reports I usually would get, and I put it on myself, and I turned it way up and I couldn't get any, you know what I mean? So, you know, if you're thinking something's wrong with something, check it out, get it checked out. So get it inspected sooner. Damage to sound head. You know, this is another thing I told you guys yesterday, that when I graduated college, I was really afraid of these modalities, very much so, because my instructor had us do things that were scary. Like he had us hold the ultrasound stationary until it started to hurt, and you know, he made us he was worried we were going to hurt somebody, obviously, and he really scared us enough that we were probably all terrified of even using that modality. But needless to say, we also were told that if you ever expose your head to air, you know, never let your sound head be exposed to air, or it's going to break.
It'll shatter the crystal.
Right. Yes. Yep. So I was worried about the shards getting in my eye, you know what I mean? So the fear. Yes, your sound head should not be exposed to air. That is absolutely true. There are manufacturers though, there are machines now that they will tell you it won't come on until you're in contact. That you can, and the great ones back there, they say you can lift up and it'll go off. Am I gonna lift up and let it go off? No. I was trained, it's too deep ingrained in my head that you cannot do that. But exposing the crystal to air is something you shouldn't be doing. Now, I do think they're more durable than they used to be, so if you accidentally go like this and say, whoa, I'm not worried you necessarily broke your sound head in one time, but some manufacturers have now got, what I've been told is that it's a thermal sensor, so if you lift up, if it gets hot, it's gonna shut off. If it starts to get hot, it'll shut off. So there are machines, like the blue and white ones back there have no ability to do that. It will beep and eventually shut down, but you're supposed to not expose it to air. But if you're doing a treatment and there is air getting in, that crystal can start to heat up and the machine will beep at you and it'll tell you you're not in good contact. And you're supposed to correct that. So the blue and white ones, it'll say beep, beep, and eventually it'll shut off because it's saying you're not listening to me, so I'm just gonna shut off before you break me. So some machines have these safety precautions that are meant to protect you from damaging it, or if it's accidentally left on or something like that. But just avoid exposing it to air and then you won't have any problem whatsoever. Yes, ma'am?
So basically when you start doing ultrasound, when you put the gel, you turn the machine on before or after you?
I put it in contact first and then hit start.
And then when you're removing it, you just shut it off before?
I would hit stop and then remove it. So good practice would say, put the gel on a clean head with clean hands, especially, if you're gonna use a bottle on more than one person. And then once you've done that, don't touch it again. Put it in contact with the patient and then hit start. And then start moving immediately so that you have good uniformity. Yes.
Okay, this might be a stupid question, but because you don't want to expose it to air and all that, do you turn on the machine and do all the parameters and then do the gel and put it on, or do you have to put the gel and all that stuff before you turn it on and then?
So for the setup, I'm not aware of any machine that you can't turn on, get all the parameters set up and ready to go, get your gel on, put it in contact, and then hit initiate the start button.
Okay.
So I'm not aware of any machines that don't allow you to do that. But you could set up all your parameters first, get your gel on, get it in contact, and then hit start. So these machines back here, that's what you'll do is you'll then hit start. Okay? Damage to sound head, if the sound head itself, it'll be warm, and you'll notice when you're done with your treatment and you feel the head, like right now this one feels cold, but when you're done with the treatment, it will feel a little bit warm, but you should be able to touch it. It shouldn't be so hot that you can't touch it. If that's happening, something's wrong. I've never had it happen, knock on wood, but I've heard that it's happened before, that people have had the head get so hot that it could potentially burn somebody. So that shouldn't be happening, and if it is, find out why. Get the machine injected, get something's wrong with it. Maybe the feature that's supposed to shut it off isn't working, the crystal's not working right, something's wrong. I don't know what it is, but something's gonna be wrong with it. There is a simple test for output you can do where you put a piece of packing tape around the edge so it creates a well. You can scoop up a little bit of water and you can turn on the ultrasound. And when you turn it on, you can see it going through, you can look at it, and you can get a little bit of a visual of the ultrasound energy as it passes through. And that can show you that, oh, I dropped it and it still works. I can't be sure that everything's proper, but I can at least say it's still working. I've had cases where somebody said, maybe it's a new building I'd never been in or something, he said, well, we have an ultrasound, but we haven't used it in years. I go dust it off and turn it on and put the water on it and see, does it do anything, And if it's even working, then I can have somebody come in and assess it and calibrate it and so forth. It doesn't work at all. We either get a new one or I send it to the manufacturer and ask them, what's wrong with this, is it worth fixing? Infection control, I think we've pretty much talked about that. Would you agree? We've covered that pretty well. Proper electrical outlet, I don't know if I need to say this to anybody, but don't take a 3-prong and turn it into a 2-prong. I mean, the only time that might be a problem is if you do home health and it's a really old house or a garage that was converted or something and they don't have proper GFI outlets. So anything that plugs in the wall is intended to, the wall outlet is intended to protect you in the event of a dangerous level of surge of energy. So you should be fine so long as you're using an appropriate electrical outlet. Battery powered